send us pictures of your ECMO team. So you can reply with 1 or 2 pictures of your team on the email that you had for your registration, or you can email congenitalheartacademy@gmail.com. But you can just reply the email that you got. Okay, so in July the 9th, we are going to have ECMO Part 2, and we want to share all of your ECMO teams. This is my ECMO team in my former hospital in São Paulo. And the other picture that we had before is my actual hospital here in Qatar. A little bit of Zoom education. When we start, I hate this computer. Okay. So when we start the presentation, we are going to have on the top these, it's very, very hot here in Doha. It's 45 degrees and my computer is not happy with that. So when you're going to have on the top called view options. So here, so if you click this side by side, if you click side by side, you are going to able to see the entire screen of the presenter and not the video on your left, on your right side. Okay, so go to view options and click side by side mode is going to be a better way for you to view the presentations. And if you can choose to have gallery view or speaker view, if you want to see all of us, you can go to gallery view. Okay, and we have on the bottom of your screen the chat. So when you write, please click all attendees and panelists so you can talk to everybody. You can make comments and everything. And if you want to give a specific question about the presentation before or after or during the presentation, please write in Q&A and we are going to try our best to answer all of your questions. Okay, so that's what I have for now. Sasha?
Yes. So we start thanks everybody. As we start every time with this meeting, we say good morning, good afternoon, good evening, because at the same time, at the moment, we have more than 900 people from around the world, and this is a big satisfaction for us. We join our results, and I would like to share with you the big opportunity to have such a unique speaker staff that Grace was able to invite and put together for an amazing day. So we start with Tom Brogan, that will talk about should every cardiac center have an ECMO program, and should all ECMO program join ELSO? He's asking 2 questions. Tom Brogan is an attending physician and ECMO director at Seattle Children's Hospital and associate professor of pediatrics at the University of Washington School of Medicine. And this is one of the editors of the Red Book. So thanks, Tom, to be with us. And if you share your screen, we start.
Can you start with the poll, Sasha? While he is starting that, we start with the poll, with the 3 questions, the 3 first questions for the audience.
The 3 from Tom?
Yes, the 3 from Tom
Now.
We are going to have the poll first, Tom. Yes. So if everybody can please answer this first question.
So very fast, we joined more than 60% of people. I can say that we can stop here.
Okay.
Because the sort of
yes, please.
Clear answer.
No.
So this is for you.
Okay, 74% of people who is attending has an ECMO program in their centers. Okay, next one.
Next one. Again, should every center which perform heart surgery have an ECMO program? And again, 0 no. More or less 0 no. But now no is coming. I think that we can stop here. We have more than 70% of people who is already. Grace.
Okay, Tom. 90% Tom said that every cardiac program has to have should have an ECMO program. Okay, the next one.
Yes. We go to the next one. Should all ECMO programs join ELSO? ELSO must be happy. is again, okay.
Okay, 85%. Okay, Tom, so you have a lot of things to start your presentation. Thank you very much for being with us.
Okay. First, I'd like to thank Grace and the organizers for inviting me. I'm honored to be on this program with this august panel, and I'm really impressed that people from all around the world have joined us. So welcome, everyone. My name is Tom Brogan. I'm from Seattle. I've had the joy of working on the Red Book and the Specialist Manual, and I know a lot of the people on the panel, so I'm quite lucky. Oh boy, now it's not advancing. Oh, there we go, sorry. Okay, I have no disclosures except that I discussed this with Ravi Thiagarajan, who runs the cardiac program in Boston. The nice thing about Ecmo, when you start talking about cardiac surgery programs, is that Ecmo is a very useful tool because you can use it at the point of care. You can go from the OR to the ICU, and if you need to put a patient on there, you can cannulate in the ICU, or you can go straight to Ecmo in the OR if the patient cannot be separated from pump. You get cardiac and respiratory support. We can take care of patients with any defect of any size. We can cannulate them centrally or peripherally, and there is a very, very great experience of using this tool in cardiac patients around the world. So there's a lot of experience and a lot of help. And this is what the pump looks like. For those of you who don't have one, this is one type of pump. And so in discussing whether it's useful to use cardiac ECMO or to have an ECMO program in a cardiac center, there's a nice paper by Susan Bratton and Ravi Thiagarajan and a few other people from a few years ago where they looked at the FIS database, which is a database of 43 freestanding children's hospitals in the United States. And they looked at cardiac, surgical, and ECMO cases. And in that study, they found approximately 130,000 cases. And of those 130,000 pediatric cardiac surgery patients, 3,700 went on to ECMO, so just under 3%. The overall surgical mortality of this 130,000 patients was 3.5%, and the mortality in the ECMO group was 47%. But the important thing here is that of the patients, because 3,700 patients went on ECMO, it actually decreased the total mortality by a median of 30%. Now, this graph is a little bit busy, but I try not to get too involved in looking at it. But I will just tell you that the line that runs horizontally is the median improvement in survival of cases, and the line that runs horizontally instead of vertically is the median number of cases who went on ECMO. And then the authors divided the ECMO centers into, or the cardiac centers into the number of cases per year, going from the least to the most. And if you look at this graph, the two things that you see very easily are that in the bigger programs, there tends to be more cases that go on ECMO. And the survival is rather variable. So the more experience you have with ECMO, the better you tend to do with it. But it's not simply a case of size matters, although size is not unimportant. So it can help us, ECMO can help a small program and it can help large programs. Now, starting a new program is rather complicated. And Jana Assay, who's in Beirut, Lebanon, and did her training in France, went and started an ECMO program there. And she has a very nice publication in, she and her team in Perfusion last month, in which they discussed their methods for starting a program. And I don't want to go through all of this because it would take a lot of time, but the paper is very nice. And there are other educational modes and resources that you can use if you do want to start a program. I see about a quarter of the respondents do not have an ECMO program. Now, there are downsides to ECMO programs. The most obvious and easiest one is that the startup is rather expensive, and that's going to depend a little bit on what you're trying to do. You also have to create a new team, and that requires training and simulation in order to get the team up to speed, and then to keep the team competent and able to respond to any emergency. And again, because ECMO is at the very edge of our technological and clinical capacities, sometimes it's very hard. And so the simulations, as the video from Michigan shows, have to be quite realistic. And again, ECMO is hard, so patients are sick and things go wrong, and that can be quite challenging for the team. So in addition to starting a team, you have to create a structure to help support the team. You have to figure out what kind of trouble you're going to run into, and you also have to figure out what resources you have in your institution that can help you with those problems. Now, I bring up these points because it's obviously not straightforward or easy, but the thing that I did not put on this slide is that it actually makes your other teams better at what they do. So you actually improve the care in your ICU when you start doing ECMO, because there's nothing more complicated that we do in the ICU than a complicated ECMO patient. So it teaches us all to be better at what we do. And now, just to switch gears a little bit, the second question is, should all ECMO programs join ELSO? And so the answer is yes. Next question, no, I'll talk about this briefly, but I really strongly encourage all of you to join ELSO, because ELSO right now has more than 700 member institutions, and there are also individual memberships. From that, we get data from most of those centers. We're still trying to get all of the centers who've joined to submit data, because that's what's taught us. Dr. Bartlett started the registry back in the 1980s. There are actually some cases from before 1989, but really it came online in 1989, and there are more than 100,000 cases in the ECMO registry. And from that, in the registry, in addition, the registry tracks 684 different devices that get used for cardiac ECMO support. The other thing about the ELSO registry, which has been very nice, is that it's been rather flexible. So addenda get added to the registry in order to track new issues. For instance, when COVID became an issue, Ryan Barbaro, who runs the registry, was able to get an addendum, and now we have data on COVID, which is helping us all around the world to care for these patients. There are hundreds, there are probably close to 1,000 now. It's hard to tell when you look on PubMed, because not all publications that use the registry actually have ELSO as a keyword, but there are hundreds and hundreds of publications that have used the data from the registry that have helped us learn. Other advantages of the ELSO membership is that from the data, you get reports back from ELSO that allow you to benchmark with similar programs and allow you to evaluate your outcomes by indication or by procedure. And I'll show you a screenshot of a benchmarking slide in a second. But in addition, if you have any questions, you can send a query to the ELSO people, Peter Reiches and his team, and they can send you data on whatever you want to find it out. And they're quite good at getting that to you quickly, which may help you with a patient that you're taking care of or a patient that you're considering for ECMO. And additionally, recently, ECMO has added the Arbormetrics, which has helped us to improve our benchmarking statistics. There are many quality metrics that are listed on the slide, and you can actually, if you're not a member, you can write Peter and get an idea of what the data entry looks like, so you see what data you would have access to. This is, again, a benchmarking slide. I tried to cover the name of the hospital for the sake of privacy, but it just shows you, it compares the hospital to all of ELSO, and then the age group. You can look at it by year. You can look at it by pediatric patients, adult patients, neonatal patients. So there's a lot of possibilities with the database. ELSO also provides lots of education, including webinars like the one we're on right now, training courses. Lakshmi Raman, who's on the panel, is the head of our protocols, and she works quite hard with that. There are textbooks that we produce, the Red Book, specialist manuals, and now there are monographs that are coming out, and the first one should be out this year with any luck. So there are a lot of resources, and in addition, there's also the Center of Excellence, which helps you review your own program. This is from Grace's old program where she trained, where they looked at their function. And I'm going to actually stop talking now because we're almost at the end. But this is perhaps Grace can chime in now and tell us about her experiences because it was quite helpful in taking care of her patients.
Thank you, Tom. Thank you very much. And this is a great honor to have you talking to us about it. And I want to tell, this was experience of the INCOR, the center where I've trained in Brazil. It's a very busy cardiac center, and maybe the biggest in the country. So when I was a trainee, ECMO was something that it was not good. Can you see the blue phase? So you have few patients of ECMO and almost none going home. So for us, it was something that was not worth it. But then I left. I went to a private hospital, but people from INCOR were already trying to figure out what was going on because they could see the publications that ECMO was good. So they went to Canada, where the center of Daniel Garros. He can say a little bit about it as well. They went there to learn, to restart, to get better equipment, to get everybody trained. So they went there, they trained, they came back to Brazil. They start to train the team, the nurses, the ECMO specialists, everybody, and then people from Canada, from ELSO, comes to Brazil every year to give another training course. So it was very important in the experience of our country. And now people who knows and have been trained can share their experiences. So we give training courses. Well, I use it too. Now I'm in Qatar, but when I was in Brazil, I was part of it. But they continue doing this great work of going to other cities and other states of the country to teach ECMO. And on my the private hospital that I used it to work for, we had a different experience that is worth sharing as well. So we decided that we are going to start an ECMO center. So ELSO helped us in a sense that it was a roadmap. How should we are starting from scratch. We don't have an ECMO center. We don't have an ECMO program. How are we supposed to make our ECMO program? So we decided to look at the award of excellence. What would be the requirements for that? And the first line says, is your center an ELSO member for the last 3 years? I said, okay, so we have 3 years to make a good ECMO program and try to get it. So we used that as a roadmap, how to train the team, how to settle our program, how to give education about equipment, about everything. So this is our experience of my other center from Sabará, that we try to follow those requirements. And in the end, it was a very nice way to build our program. And I just want Daniel to say some words about the training that he does in Brazil and other countries of Latin America. And I personally need to thank him because he is a good friend and my mentor. So I think that we are able to train, and I was able to train, and now I'm able to help people to train themselves as well and have a good program. And that's what we are doing here in Qatar as well. That's it. Danny, if you can say something.
Yeah, so thank you very much for the opportunity. This is a privilege to be around this table with experts in this topic. And indeed, we have been in a partnership with the Brazilian people. I started because we were friends initially, and then continue in terms of education. The group from Brazil came here in 2012, learned how to do ECMO, 5 people, and they went back home and started to modify the way that they did it. And they were doing ECMO already, all of them, but they started to do it in a more methodical way and had the proper training based on the ELSO data and in terms of how to run a ECMO program and the equipment. And then since then, we have been doing once a year, we go to Brazil and teach. I already told them that we don't need to go anymore because they are very good now and they can teach others, but they still insist because they want to continue to be on the top of the curve, and they want to be able to incorporate everything that we do in North America within their possibilities. And that's been a great partnership. And the INCOR Institute and also have been partners on this, and we have been just the instrumental instruments to provide this course. So in fact, I'm very proud to say that many people today, adults, are being saved during COVID-19 because of the ECMO that people learn with us in Brazil. And this is a moment of joy to see that they are experiencing almost 50%, if not more, survival on ECMO on patients with COVID-19. So this is a rewarding thing to hear after we dedicated 8 years of continued partnership with the Brazilian folks. And I'm proud to say that by the grace of God, this has been happening and now people are seeing the results.
Okay, thank you, Danny. Sasha?
Yes, it's time now to come in the field of neonates. It's time to involve Peter Roeleveld, who is a pediatric intensivist from Leiden in Netherlands. And he has a special interest in ECMO, and of course is a member of ELSO. So Peter, thank you very much to be here with us.
Hello, Sasha and everybody else. Grace, thanks for inviting me. You've given me a very nice topic that I like a lot. I won't be able to share everything in 15 minutes, so this is going to be an overview of some of the things that I think are very important. And we have a great panel today, so many of the things that I won't be able to touch upon, I'm sure will be covered by the others. I have no disclosures, and I'm just going to tell you what I'm going to tell you. I'm going to tell you that hospital survival in these children is approximately 45% for cardiac ECMO in general. This is a whole group of different cardiac indications, and that their survival depends on their diagnosis, on their age, on the reason they went on ECMO, how sick they were before ECMO, how good we are at restoring their systemic perfusion, how long they're on ECMO, and most importantly, how we can find residual lesions and if we do it quickly. I'm not going to tell you anything about the actual management, about ventilator, inotropes, anticoagulation. There's just not enough time for it. And like I mentioned, there's a lot of issues that are going to be covered by our friends later on today. A very quick overview of VA ECMO in a neonate. You can cannulate the baby, as you see on the left, directly through an open sternum, take the venous blood right off the right atrium and oxygenate it in your ECMO system and get rid of the CO2 and then perfuse the blood back into the aorta. Or you can do it peripherally via a cannulation through the neck. The main goal of ECMO is, of course, that we want, if we're talking about cardiac ECMO, is to have cardiac recovery. We need to make it as simple as possible for the heart to recover, give it time to heal, rest it, and make sure we don't stress it. And that all while we make sure that there's adequate oxygen delivery to the tissues. And while doing that, we want to minimize all the harm that we can do with our ventilators and other drugs that we give. So we want to minimize iatrogenic harm. In general, we assume that there's going to be recovery possible. So we bridge to recovery, but we don't always know that for sure. So we might bridge to a decision or further diagnostics. And in some instances, you may bridge to transplant or VAD, which for these neonates is not always an option, not even in a country like ours, in the Netherlands. A neonatal transplantation is hardly ever done. So I think across the world, bridge transplant for babies is it's not very often done. Like I said, survival is about 45% for these babies. This is an ELSO report. This is one of the things that we learned from ELSO, so we can compare our own results with ELSO results and see how we're doing. So the overall result about 45%. And this is important to know. ECMO is not for a lifesaver for everybody. If you start a program, you have to know that 1 in 2 children is going to die and it's not going to make it. This is important to know for your team, to make sure that everybody's on the same page and has the same expectations, not just you or the team, but also the family. But once you get a little bit better at it, it's all about finding the right patient at the right time. I love doing ECMO because it's so physiologic, but one of the hardest things is deciding when does somebody go on ECMO and who's going to benefit from it. And that's one of the other things that I really like from ELSO and from ideas like this webinar. We can very easily approach each other and ask each other questions and help each other with difficult patients. So it's a very tight community, actually, which has been very helpful to us. On a side note, I'm going to leave that slide because of time. So indications for VA ECMO are either cardiac failure. We can have surgical or non-surgical cardiac failure. I'm not going to talk about the respiratory failure or eCPR or the prophylactic support. But what I said is, when are you going to start ECMO? What are the entry criteria? And well, usually it's mentioned when conventional means are no longer adequate. Well, conventional means for me might be different than your conventional means. And it's hard to find very precise cutoff points as to when a baby would benefit from ECMO. Let's just focus on the congenital defect. So depending on the defect, depending on the age of the baby, survival will change. And there's different indications. It's a heterogeneous group. If you say 45% survival in all cardiac babies, that's the surgical patients, it's the non-surgical patients, it's a different diagnosis. Every child is different, but we can use it for preoperative stabilization. I think we talked about it a little bit in the last webinar in TGA patients. If they have pulmonary hypertension before the operation, sometimes they require or receive ECMO for preoperative stabilization. We use it in children who fail to wean off bypass. I'll get into that a little bit later. We use it in children who are weaning off bypass but are struggling in ICU with a low cardiac output syndrome or with arrhythmia or the ultimate low cardiac output syndrome, the cardiac arrest, but that's eCPR and that's going to be spoken about later. I'm not going to deal with the non-surgical issues at the moment. So if you have a cardiac program, you do congenital cardiac surgery, approximately 1 to 5% of these patients will receive ECMO worldwide. It depends a little bit on the study, and you can see there's a variation because the indications may differ, and I may put somebody on ECMO a little bit sooner than one of my colleagues, or one center may be a bit sooner than another. But the variety is about 1 to 5%, and in a very large STS database study with over 90,000 patients, I think in about 2.5% children neonates received ECMO. And this is that study that came out a few years ago. Again, a little bit of busy slide, but what it tells you is that the younger you are, the smaller you are, the longer your operation lasted, so the longer you're on bypass, the more chance you have of receiving ECMO. And the more complex your operation, the more chances you have of receiving ECMO. And I've put receiving / requiring because I'm not always 100% sure that the baby who receives ECMO actually needed it. But this is what we know. Many of these patients receive ECMO, and we all do it with our best intention. And with that, we achieve 45% survival in children that would otherwise probably not have survived. And we know that certain operations have a higher chance of receiving ECMO. We all know the hypoplast, the single ventricles, which will be spoken about later on. But if you look at other operations, like a Ross Connor operation, if that child requires ECMO, he has a 70% chance of dying, which has an odds ratio of 70. If you require ECMO, you will probably do very, very, very poorly. So we will try everything to keep somebody off ECMO. Well, these are the risk factors. You can look them back on YouTube. So the timing of ECMO, when do you go on ECMO, is, like I said, one of the most difficult things. What you want to have is a happy cardiac surgical team. You know, they're laughing and they're happy and the operation went well. But that's not always the case. And if somebody fails to wean off bypass, the first thing the surgical team will do is they will start looking for residual lesions. They will do an echo. They will put them back on bypass. They'll have another look. They will do everything to try and find the residual lesion if that's something they can deal with, and then they will try again to get off bypass. Maybe they come off bypass and they struggle a little bit and they develop low cardiac output syndrome, and you have a child in ICU who is on maximum medical therapy who might receive ECMO. There's always a debate: what is better? What's the best time? Somewhere along that sliding scale, it's probably better to get on ECMO as soon as possible. But then again, you might put somebody on too soon who didn't really need it. So finding the right time is something that you really have to learn and discuss with your team in your institution. What you think for that child is best. There are unfortunately cannot give you any hardcore criteria as this is the moment. Not possible. If you look at a few studies, they might suggest, like I just mentioned, that going on early in OR has better survival than when you go in ICU. Although in a large study recently done, which Gil was also part of, they did indeed see that the longer time was between the operation and the moment of starting ECMO, that these children were on ECMO longer, they were on mechanical ventilation for longer, they were in hospital longer, but the actual mortality didn't differ between the two groups. So that debate is still out as to what is the best time, and remains one of my difficulties still. Because you don't want to put on somebody too soon. I've taken this picture of internet, so I hope I'm not insulting anybody, but this child is clearly bleeding, and this is the things that we want to avoid. Anticoagulation in a baby is very difficult, so you don't want to put anybody on too soon. ELSO has published their guidelines and giving indications as to when they might start. When you might start ECMO, and they are still open to interpretation. Maximum doses of inotropes might be different for me than for you. But if you want some guidance, go to the ELSO guidelines, because it's a sure good place to start your discussion. And of course, there are also contraindications which you can find there. And for the babies, it's mainly very small. If you're very, very small, it's going to be difficult. And you do want to have a certain amount of certainty that the child is going to recover. You shouldn't be starting this just because you can. So once you're on ECMO, there's 3 principles that I quickly want to talk about. 1, we have to provide adequate oxygen delivery and flow, and I think I'm going to speed up because of time. So we have to give the baby enough oxygen, and that all depends. And it's too much to go into detail at the moment, but it all depends on the oxygenation in the oxygenator, how the flow in the ECMO circuit is, which depends on preload, afterload, your hemoglobin levels, the mixing of the native flow of the patient itself and the cardiac output of the patient itself, and the ECMO flow, the oxygen consumption of the patient. All these things combined lead to a certain balance, hopefully, and not disbalance between your oxygen delivery and your oxygen consumption, like you do in any ICU patients, basically. With ECMO, we can titrate it really, really nicely, and that's what I enjoy about it. But it's depends on a lot of factors. But basically, we start with about, in a baby, 100, 150 mils per kilo per minute of flow and see where we get. And we want enough flow to make the lactate go down and for the child to be well perfused, but we don't want too much, because too much flow might require a lot of fluid filling, might increase afterload and have other problems. So too much flow, probably not so good. But generally, we do about 80% of the normal cardiac output. And like I said, we want to restore the systemic perfusion, and we measure this by lactate mainly. And the longer it takes for the lactate to normalize, the higher the probability of death is. So one of my goals always is to try and get the lactate to normal within the first 12 hours, or at least as soon as possible, preferably. But the longer it takes, I start to worry. We want to unload the heart because we don't want it to pop. You know, we don't want to stress the heart. We want to make sure that it recovers nicely. And what do I mean by that? Well, what can happen is something that's called cardiac stun. The heart is already stressed. It's having a hard time, and that's why you're going on to ECMO, and then you're sucking it empty via your venous cannula. You're providing afterload with your arterial cannula, and that can make the heart make it very difficult for the heart to eject blood over the aortic valve, and your arterial pressure curve can disappear, and the heart can swell, and that can compromise the oxygenation of the heart itself because of the stress that's on the coronary perfusion. And that way the heart is not gonna get better very quickly. It's sick, and if you're going to keep it under stress, under duress, it's going to have a hard time recovering. So the question is, what you want to do is you want to unload the heart. You want to release the pressure. And again, the question is, when do you do that? There's certain ways that you can do it. You can reduce the afterload, reduce the flow, make sure the heart is a little bit fuller, and maybe it ejects a little bit. You can use some inotropes, but you probably wouldn't want to do, you don't want to increase the heart's oxygen consumption. But if that way the aortic valve opens, we consider it, and we might give a little bit of adrenaline, of dobutamine or milrinone, something to make sure that we have some ejection. But then you can go and go invasive and do balloon septostomy or surgical atrioseptectomy or a left vent, or there are certain things that you can do. And the question is when? Well, some people do it electively. It has been shown that if you do it electively, that the children are on ECMO less long and in ICU, but the mortality is similar. There's people who do it when you see pulmonary edema or when you see spontaneous contrast. I think those two are really the moment that you should really go on and decompress the left ventricle. I think you have to be quite aggressive, because your aim is off ECMO as soon as possible. And you have to find out why the child is on ECMO anyway. And that's important. I'm sure Jackie will talk about this later, but you have to find out why. And if there's a residual lesion, you want to find it and you want to fix it. And the way of doing that is, I love echo, but it doesn't find the residual lesion always. In this study, 20% was only found by echo and the rest was found by cath. So you should have a low threshold of going to cardiac cath lab to find your residual lesion. And you should probably do it sooner than later, because there's a few studies now that show that if you are sooner to find the residual lesion, you have better survival, less time on ECMO, and better survival to hospital discharge. The one on the right, there's a difference in survival between 3 days of your cardiac cath, but the other one on the left, even a difference between day 1 and day 2 already has a significant impact on your survival. If you can find the lesion quickly and fix it quickly, you'll get your patient off as quickly as possible. Because that's what we want. We want the children to leave the hospital, and we want to find those residual lesions. And all the other factors show that how sick the patient was before ECMO, low pH, high lactate, been resuscitated, makes the hospital survival lower and lower. And also the duration of ECMO, the longer you're on ECMO, the less likely you are to survive, because you run into problems, you run into complications, or it shows you that the heart just doesn't have it in itself to recover. The longer you are on ECMO, the higher the probability is of death. It's been shown in several studies. And what do we look at? When can we get off ECMO in these, also in the babies? Is there recovery of ejection? And if ejection doesn't recover after 2 to 3 days, we start to worry. This is so probably after 3-4 days there should be some recovery, and you should try to get off ECMO. And now my slides are not working anymore. Have you stopped? Have I run over? Oh, there we go. I'm almost done. So in a postoperative patient, we expect to have ECMO for 3 to 5 days. And of course it can be sooner. And of course it can be longer in some patients. But in general, it should be a short run to recover, to find a residual lesion and fix it, or to get over your low cardiac output syndrome and get off ECMO as soon as possible. Myocarditis will be spoken about later on. So in conclusion, in these babies, overall survival about 45%. The younger you are, the less likely you are to survive. The sicker you are before you go on ECMO, the less likely you are to survive. The longer you are on ECMO, the less likely you are to survive. And the sooner you find the cause and identify it and fix it, the higher the chances are of survival. So that's one thing that you can do: actively search for the problem and try and fix it.
Thank you, Peter. It was a very clear, very important message. As a surgeon, I prefer to look to the 45% rather than to the 55%, because we see, of course, as an option, as you found, is very important to find a residual lesion or something that must be improved. So now the next speaker, we change from the heart, we go directly to the brain. We ask Professor Lakshmi Raman. Is the chair of ELSO Guidelines and Protocols, is Associate Professor of Pediatrics at University of Texas Southwestern Medical Center of Dallas, Texas. Thank you very much, and we are very waiting for your news. If you share your screen, we are ready.
Good morning, everybody. Can everyone hear me?
Yes, perfect.
One second, I'm just going to share my screen. Are you able to see the slide show more?
We can see it.
Okay, thank you. So thanks to Grace and the organizing.
No, we can't. We can't, sorry.
Lakshmi, we can see.
You can see it?
No.
No, okay, one second. It is in the slideshow mode. One second. I thought we had it. Because when I go to the slideshow mode.
No, we don't see your screen. See if you have 2 screens?
I have 2 screens, but I am sharing here. Let's try this now.
because we can't see anything on your screen, not even the presentation. We don't see nothing, no.
No? No?
No.
Because I am sharing the screen. Let's see, maybe this, one second, here. Can you see it now?
No.
No? Share screen. Oh, here. Now I know what the problem is. Here. Can you?
Perfect. Yes.
Can you see it?
Yes.
Okay. Sounds good. Thanks to Grace and the organizing team for.
But we don't see your presentation.
We see a feedback survey.
Here? No?
The presentation
No.
is behind, but we have to
Oh dear. New share. Now?
there is a window open of feedback survey.
Not. Still not?
Yes. Yes.
Yes. Yes. And it is in a show mode?
Yeah.
It's okay. It's perfect.
Okay, thank you. Oh dear. Okay, sorry about that. And thanks to Grace and the organizing team for giving me this opportunity. This is a topic that I'm very passionate about. And so I've spent the last few years working on this topic. So I have nothing to disclose. In the next 10 to 12 minutes, I'm going to show some of the background about neurological complications, and then the various neuromonitoring and what we have done locally in our center, and then what really we have to think about for the future. So this is the latest ELSO International Registry data that shows for the various patient population, and you can see how the survival to discharge, and this is the neonatal group, and this is the pediatric group. And then I want to say that once you do have a brain injury on ECMO, how your survival percentage drops down significantly. So this is an important cause of morbidity and mortality on ECMO, and we have to be cognizant of that. So this is again from the latest ELSO registry report, where we can track the complications, and you can see over the trend of the last several years. I think we're getting better and better at doing ECMO, but I still feel that we haven't figured out what the issues are with neurological complications, and our complications are still significant, and our percentage of survival is low. And this is for the neonatal group, and this is for the pediatric group. And once you have a neurological complication, your survival drops. So what puts the patients at risk for neurological complication? As you can imagine, these are some of our sickest patients in the ICU. We take patients who are hypoxic, who are acidemic, who are ischemic and hypoperfused, and then put them on ECMO and expose them to inflammation. You have to give anticoagulation. They already have alterations in their intrinsic anticoagulation. They can develop microthrombi. And then if you're on VA ECMO, you have loss of pulsatile flow. And all of this can cause changes in the cerebral blood flow and drainage. So the next few slides, I'm going to talk about the various neuromonitoring and how we can use the neuromonitoring to help identify injury. So as you know, the standard is best is if you can get a clinical exam, and that is the best neuro exam that you can get. But all of us who do pediatric and neonatal ECMO know that we don't have this luxury many times. These are patients who are sedated and sometimes even paralyzed. And so we don't have that luxury. Then next, let's talk about serial head ultrasound. I think this is very nice because it's non-invasive, it's readily available, it can be done at the bedside, your patient doesn't have to be transported. And but unfortunately, you can only do it in the neonatal population or in young infants who have an open fontanelle. But at least it helps us prior to going on ECMO to make sure that they don't have a big intracranial bleed, which excludes them from putting them on ECMO. And then you can get some serial head ultrasounds to make sure that they don't have a big neurological injury. Then EEG, I'm going to spend the next couple of slides talking about EEG. I think EEG, more and more centers are using EEG as the standard of care. This was a recent study from a single center in New York from Columbia, where they routinely did EEG on their pediatric and neonatal Ecmo patients. And then they classified, they had a total of about 70 patients, and of which 54 of them didn't have seizures and 16 of them had seizures. And in actually the 16 patients, half of them had only subclinical seizures, which means these were patients, if you didn't hook up a EEG monitor, you would not have recognized that they had seizures. And you can see patients who had seizures were younger, they were smaller. And what were they then? They went on to look at what were the risk factors. So they looked at the worst blood gas prior to going on ECMO. And they found that these were patients who were acidotic and their bicarb was lower. And they were also hypoxic. And though this was not statistically significant, and similarly, they had higher lactates compared to the patients who had no seizures. And then, of course, not surprisingly, they had radiological evidence of injury in patients who had seizures compared to the patients who didn't have seizures as well. I want to talk about cerebral oximetry. In many ICUs, at least in the United States, cerebral oximetry is the standard of care at the bedside. So what is cerebral oximetry? It utilizes the principle of absorption of near infrared light, and the absorption is different between oxygenated and deoxygenated hemoglobin. And this you measure as a cerebral oxygen saturation. So what do we know about the use of cerebral oximetry in ECMO? These are some early studies in the 90s where they did it on neonatal ECMO. And they found that to be mainly descriptive in nature. They found that there were changes in cerebral oxygen tissue oxygenation around the time of cannulation, but however, there was no correlation with imaging or outcomes. This was a study published in 2012 in adult patients. And here they followed the cerebral oximetry over the course of time. And if the cerebral oximetry decreased significantly, then they would do some interventions at the bedside, like optimizing the hemodynamics, increasing the ECMO flows, giving them blood transfusion. And then if the cerebral oximetry didn't improve, then they took them down for head imaging, and they found that patients who had persistently low cerebral tissue oxygenation had either focal infarct or diffuse anoxic injury. Similarly, this was a pediatric study published in 20, where they found that the mean cerebral tissue oxygenation was lower in non-survivors compared to survivors. And even among the survivors, patients with brain injury had lower cerebral tissue oxygenation compared to the non-survivors. So we have, in our center, we have utilized the concept of this cerebral tissue oxygenation and used it to identify abnormalities in cerebral autoregulation. So what is cerebral autoregulation? It's an important hemodynamic response that helps to preserve the brain blood flow in the face of changing cerebral tissue pressure. And failure of autoregulation is associated with poor outcomes, and we know that from traumatic brain injury, strokes, and other types of brain injury. So how have we used the cerebral tissue oximetry? We used a principle called wavelet transform coherence. What is this? It evaluates the dynamic relationship between spontaneous fluctuations in blood pressure and changes in cerebral tissue oxygenation. This has been applied in neonatal HIE patients, and from Great Ormond Street, they have used this for neonatal ECMO patients. But what is new that we did, we applied this dynamic relationship to evaluate the disturbance in cerebral autoregulation over time. We called that autoregulation index. And then we asked the question, can this relationship be used to predict intracranial events? So this is a graph which shows the autoregulation index in the x-axis and the neuroimaging score in the y-axis. And as you can see, if the autoregulation index got higher, which means abnormal cerebral autoregulation, it was associated with higher neuroimaging scores. You do see here a group of patients who had low autoregulation index, but did have higher neuroimaging score. And of the 5 patients that you see here, 4 of them actually had cancer and so had some degree of cerebral atrophy. And 1 was a neonate with GBS meningitis who ended up on ECMO. So we find that cerebral tissue oxygenation can be a surrogate marker for cerebral blood flow. So then we went on to ask the question, can we differentiate the type of injury, whether ischemic and hemorrhagic injury behave differently? So in our cohort of 47 patients, we get minute-to-minute cerebral tissue oxygenation and blood pressure measurements. And then we normalize the blood pressure for age. And then we looked at the bins of blood pressure that they were spending through their entire Ecmo run. And then we had patients with no injury, ischemic injury, and hemorrhagic injury. And we found that hemorrhagic injury patients spent a significant amount of time in their higher blood pressure range compared to what was normal for them. Even though they had higher blood pressure range, their cerebral tissue oxygenation was lower. And then when we went on to look at the autoregulation index in these patients, we found that actually the autoregulation index was most disturbed in ischemic patients compared to either the no injury patients or hemorrhagic patients. So what have we learned so far from this? That we found that cerebral oximetry can be used as a non-invasive measure of cerebral autoregulation, and that autoregulation index correlated with neuroimaging scores. And there is a difference in cerebral hemodynamic profile between ischemic and hemorrhagic injury, and that ischemic injury patients, it is a pressure dependence, suggesting that there is impaired autoregulation. And I think this is important because to understand and know this information will help us manage these patients' hemodynamic profile when they are on ECMO. The next few slides, I'm going to talk about neuroimaging and the various modalities of neuroimaging. So this was a study done by Ravi Tyagarajan from Boston, where they looked at their head CTs and patients with VA and VV ECMO, and compared the patients who had either abnormal CT to patients who didn't have a CT or a normal CT. In their cohort, they had 49 patients with abnormal CT, and they had 33 patients with normal CT and 99 patients with no imaging at all. And then they went on to look at what were the risk factors. So these were patients who had also electrographic seizures, not surprisingly in the patients who had either infarction, and more so in patients with infarction. They also had higher lactates, suggesting that these were patients who were much sicker. And when they looked at their survival, patients who had abnormal CT had a lower survival, and particularly the ischemic patients compared to patients who had a normal CT or had no evidence of imaging abnormality. And when they looked at their outcome scores using the PCPC, they found that to be abnormal as well in patients who had injury. In our center, I'm going to talk about the next few slides with our center practice. In our center, we have made it the standard of care to get post-ECMO neuroimaging and MRI, particularly in our pediatric intensive care population. And we have a cohort in our group. This was a study done by one of my fellows who's just finishing up his fellowship and ready to submit this data. And we reviewed all our neuroimaging. We had 104 MRIs and 28 CT scans. And then he went on to do a neurodevelopmental assessment using the PCPC and POPC in the survivors. And then we tried to establish a validity of the imaging as a predictor of outcome. What was very interesting is that in our cohort, we found that more than 70% of them have some degree of abnormality on their neuroimaging. And when we went back and looked at the clinical notes to see how many times there was even a suspicion of clinical injury, very small percentage. That just shows that we are not very good at clinically identifying neurological injury. And in fact, we are working on a neurodevelopmental and follow-up guideline led by Dr. Hot off the press from Eddie Fan's group, where they looked at actually the ELSO registry data and took patients who had neurological injury of adult VV patients, and they looked at changes in PCO2 of less than 50% or greater than 50%, and found that if you had a greater than 50% change in your PCO2, then you were at risk for intracranial hemorrhage and overall neurological complications and brain death and seizures and your ICU mortality was higher. So I think it is important when we put patients on ECMO, if they start off with the high CO2, that we may want to take time to drop their PCO2 over the next few hours rather than acutely, and have to be cognizant of that when we adjust the sweep gas. We do that in our center when we have patients with high CO2. We try to see how long they have been in their high CO2, and we take that long to come back to their normal CO2. This was a nice study where they looked from their pediatric cardiac ICU patients. This is their infant cohort, this is their neonatal cohort, and this is the cohort of Norwood patients. And they stratified them into patients who were had no survival versus survival. This is mortality yes and mortality no, and saw how much time they spent in the hyperoxia range. And you can see uniformly patients who had higher mortality in all age group, they spent significant time in their higher oxygen. This one. So where do we go for the future? I think it is important to study the impact of underlying illness around the time of cannulation, study the perturbations in acid-base balance and oxygenation and ventilation changes around cannulation time, and need for ongoing and better neuromonitoring during this critical time period. Thereby, we have to be able to predict the injury before it happens, or at least identify the injury early so we can do some brain protective strategies. Finally, I want to thank all the people who have been helpful to get this work done. Ravi, who's been helping me through his brain power. Fengwa and David are the biomedical engineers who have worked with me, my critical care fellows who have made a lot of this data possible, and of course the funding support. And finally, the members of our ECMO team and the ECMO patients. And we bring all our ECMO patients once a year back and celebrate their lives through our ECMO reunion. And I'm happy to take any questions through the chat. Thank you very much.
Thank you very much. It was an amazing presentation. Thank you really, really much. So now we are going to talk about a little bit about end-of-life care with Daniel Garros. So Daniel is a Brazilian-Canadian clinician. He's a clinical professional of pediatrics at University of Alberta in Canada. He is a senior staff intensivist at Stollery Children's Hospital and a member of the Bioethics Committee. He has been an ECMO instructor and volunteers regularly in cardiac surgery programs in less privileged countries. And as I told you before, he's my mentor and a very close friend. God bless you, my friend. I'm really thankful for everything that you have done. And you need to unmute your microphone.
Okay, so for me, it's a real pleasure to be here. And for me, it's a real pleasure to be here and talk to you about the ECMO and our ECMO program. And I think we need to go back to the first slide here. Let me just stop sharing for a second and go back. Let me stop in the, okay. So I've never spoke to so many people in my life online. Okay, there you go. So, and for me, this is a great opportunity to share experiences with bright people, as you have seen so far, and also to be able to connect with so many people around the world. So what I'm going to talk about is a bit different, but is a good follow-up to the previous speaker, because many times we are faced with the unfortunate event of an injury that we have to stop ECMO. And
Danny, we can't see your slides.
Oh, sorry. So let me see, I'll share my screen again.
Don't forget to click on that two things on the bottom side.
Can you see now?
Yes.
Everybody can see?
Yes. Yes.
Okay, good. So our objectives today is to talk about when we have to stop NVA ECMO. Can we do that? Is it right to do that? Can we do palliative care really on ECMO, and how to stop? And yes, we can do it. My disclosure, I did have some barbecues with the maque getting people in Brazil. And this is one of the pictures of our group in one of our first courses of ECMO at the INCOR Institute in Sao Paulo, and a place that we go every year. So as you know very well, I don't need to teach you this, but just to refresh that ECMO could be a bridge to recovery in case of potential reversal organ failure, like the heart, stun heart post-surgery, a bridge to transplantation in a case that the heart does not come back, or the cardiomyopathy or cardiac failure, a bridge to organ replacement when you have to extend your stay in waiting to see if the heart is going to recover, then you can put the patient on VAD, or a bridge to decision when you don't know what's going to happen, the prognosis is uncertain, so it's a bridge again in post-op cardiac many times, or allows us for investigation, diagnosis, or prognosis data gathering. So, and the last one is, but not less important, is the eCPR, ECMO in cardiopulmonary resuscitation. So these are ECMO VA that we tend to use. What we're talking today is the compassionate deactivation of mechanical circulatory support in children, and especially about extracorporeal membrane oxygenation, or ECMO machine. So this is a part of a paper that we're preparing to publish very soon with some colleagues that we're going to give some guidelines how to do this. There are ethical dilemmas, and the ethics people have been called in many situations, and this is a study out of Boston in 113 patients, and look at the difference in time. In 2013, they had about 20% getting ECMO ethics to see ECMO patients, and then in 2015 they went up to 93%, and half of them, there was no specific ethical question. They want to make sure that people are all on the same page, and this is it's a local reality, but it's just to look at what were the most common ethical issues that the ECMO was triggering on people. There were some disagreements among the team, disagreements among surrogates, parents, and the team, and then disagreements mainly that was a high topic on the consultations as over stopping or continue ECMO. Are we throwing out the towel too soon? That means, are we stopping too soon? Are we giving the right time? Is the right thing to do continuing, or should we wait longer? And this was one of the most common causes. And this is another study out of Boston Children's, the group of Dr. Wolf, and looking at all the cardiac patients that had withdrawal of life-sustaining treatment over a period of time of 3 years, and 111 patients, and you can see the diagnosis there. But I want to call your attention that when the people were withdrawn from life-sustaining treatment, where were we withdrawn from? And you can see that 92% of the cardiac patients were on mechanical ventilations, 89% were intravenous inotropes, but 46% of the people that had some withdrawal, they were withdrawn from ECMO. And that is to show that nowadays in North America, in a cardiac unit, many of our patients, they die on ECMO or after withdrawal of ECMO. This is an adult study. This is happening in adults as well, from Daniel Brody and his group based on ELSO data.
Danny,
and
sorry to interrupt you. It's very bad, the quality of your screen. Can you try to share it again? I'm sorry, we are getting a lot of messages on the chat that they can't see very well.
Oh, okay, just to see, stop share. Let's go back. It's more important what I'm saying than what is in the screen.
I totally agree. Yeah, I totally agree with that.
Okay, so let's go, because I have it open in 2 points here, that's okay.
Okay. Don't
Let me
forget to
just
click
get
on the
it.
2 boxes below.
Yeah, let me see. So I was saying that in many situations that you are on
We
the
can't see your
on
screen.
the
Not
yeah,
at all.
I know. I'm just
Okay.
talking while we're doing this. I'll start again. So what I was saying that is important to know that when we are doing cardiac surgery and we have ECMO, we will be facing, can you see now?
Still a little bit blurry, but okay. You can keep going.
Yeah, okay. So this is a study that that I was just commenting on from the ELSO registry that it shows that many of the patients that we had withdrawal of life-sustaining treatment based on removing ECMO in adults, already on the first day, they had the family requesting to stop. The majority of the cases were related to organ failure. And then the first day all the way to the 10 days, there was a significant impact of organ failure, but many cases the family had been requesting to remove life-sustaining treatment. So is there enough ethical backing for us to discontinue ECMO? So this is a busy slide. I just want to say that this article by our former fellow now working at the SickKids in Toronto, Roxanne Kirsch, and she has put it together a very nice summary of all the ethical reasons that one would discontinue life-sustaining treatment based on removing ECMO, and all the framework from the ethical principles, from the respect of persons, autonomy principle, to informed consent based on respect for people, non-maleficence, best interest, and distributive justice. All of these arguments can be used to remove ECMO. What I want to say to you that one thing that strikes to me is the importance of the informed consent. So before starting ECMO, you explained the objective. What is the bridge to decision? What is a bridge to transplant? What is a bridge to recover? And you respect the people that they have the right to know the risk and benefit of any therapy, including ECMO. And you then get the consent by starting the ECMO, and then you inform, but also you tell them that if the patient is not following the script, if the patient is not improving, ECMO is not a treatment, ECMO is a support. And what you don't want to hear is everything was decided, they told me I did not participate in the decision, like has been said by one patient in a study quoted in the literature. So the issue is you inform properly. The other important principle that is very, very important is the principle of disproportionality. So it's a balance between the benefit and the harm. We all agree sometimes that we do things that the family is pushing for us to do, and sometimes we keep the patient intubated longer, sometimes we keep the patient on vasopressors to gain more time, even starting vasopressors to give family time. Even we give antibiotics when the patients don't need it because the family is pressing and there's a context to that. But when we're talking about ECMO, the burden for the patient and the use of resources is so great, it's in excess of any therapeutic benefit. It's different. It's almost the same as having to do dialysis and somebody that has no indication of dialysis. So then it becomes very clear in your mind that the burden, it's much higher than the benefit when the ECMO has not fulfilled its purpose. So that's called the principle of disproportionality. Do we call futility? No, I don't like to call futility for continue ECMO when there's no point to continue. You should say, like this study from the Mayo Clinic, that the authors referred to potential inappropriate care or non-beneficial care. Those are more important concepts than just to call we're doing futile treatment. So let's go to some practical points. So before you start ECMO, you have to have in your unit a pamphlet or points to a website, to an app where the families can read about it. Be very clear with your ECMO objectives and expectations and the risks. We may not reach the objective or recover or transplant, so you have to then tell them that this is part of the game, and you assure the patient will be comfortable at all times, regardless at the end. And you keep family up to date, let them be part of your rounds with ECMO, and involve the palliative care team if you have one, or start principles of palliative care sooner rather than later. Like the team in New York and Dr. Brody, they have this very clear on their pamphlet that we will discontinue CLS and when the patient, the ECLS is not serving the purpose which was originally placed for. The other important thing is people quote statistics. Yes, statistics may work, like the Caesar trial in the UK. The analysis showed that many patients went in based on the statistics, but like this Eurocon study in Europe with the neonatal folks, 40% of relatives were judged not to be competent to approach for consent in a very stressful situation. So you have to remember that. A palliative care role. So as you know, today, palliative care is not like it used to be, is not end of life. Palliative care is to maintain the quality and the meaningfulness of life for both patients and families, is not limited to terminal care, but is appropriate for all patients in all stages of diseases. And for whom? Patients who qualify are patients with life-threatening conditions, and these is chronic conditions, life-threatening conditions. ECMO patients, cardiac patients are on this category, and patients that curative treatment is possible but may fail. So then palliative care has a role and is not end of life, is to be there with the patient, like this one on ECMO that we had in our center that is on the ground playing with his father and is still on ECMO connected to the machine. So we don't want to see is a bridge to nowhere. So we have to understand that when ECMO has fulfilled its purpose and there was no outcome that is positive, when the outcome is to nowhere, there's no treatment for further, the heart has not improved, like a newborn, there's no way to get a transplant, like our previous colleague mentioned. What are the options? Either you do not escalate treatment anymore or do not resuscitate. Yes, you can do that, or we withdraw from ECMO. So limitation or no escalation during ECMO, you can say, for example, for now on, let's keep talking, but we're not going to replace any ECMO parts that are dysfunctional, such as the membrane or something. If the equipment fail, we'll stop. We'll keep vasopressors in the vasodilatory shock on ECMO, that it can happen. The ECMO is not supporting anymore. You just don't progress with the inotropes, and you do not exhaust the blood bank stock anymore, so you stop the aggressive transfusion protocol. This is one way to limit or no escalation. The Mayo Clinic folks have reported that on their cases of withdrawal from ECMO, 30% had a DNR at the time of death. So they had a DNR on ECMO. The family was not prepared to remove it, but if there was an event leading to cardiac arrest, which is rare, which is difficult, we support people on ECMO, but it can happen, then we would not resuscitate further. It's much more frequent for VV ECMO than for VA ECMO. And withdrawal is compared to a cancer patient that is awake, is ventilator dependent, but there's no possible cure for the cancer. So then you remove the patient compassionately from the ventilator. So the question is, what's the difference with ECMO? So it is different because for ECMO, you have a situation where you have a patient that is not passing to a test of time many times, and then you have to give the test of time. So wait until you get all your everything lined together, and then you can withdraw when the family is ready. So what really matters is recognize the role of ECMO, that is a potentially life-saving tool and not an instrument to prevent a dignified death. So if I have to ask you to remember one thing about this talk, is this sentence: recognize the role of ECMO, that is a potentially life-saving tool, but not an instrument to prevent a dignified death. So the team needs to be prepared. I don't have time to discuss this. So, but everybody has to be on the same page. We have to understand that ECMO has failed as a means of recovery or a bridge to mechanical support. There's a major complication in some cases that has occurred. So it's no longer safe and no longer appropriate, or the family had enough and they sometimes request us to stop. And if we see that this is a reasonable thing to do, there's a very poor chance of this patient would survive anyway, then we will stop. So how do we do this? So remember two important points that I want to call your attention. One thing is stopping inotropes. The other thing is stopping ventilator, even extubating a patient. But clamping the circuit may evoke a strong and very, very disquieting sense of moral agency. So I'm doing something very big, particularly when death is a proximate consequence of this act. So this has to be very clear in everybody's mind, that everybody needs to be prepared for that. And the other thing that will help you to do that is to understand that the patient is dying from the natural progression of the underlying disease, not from your clamping of the circuit. The clamping of the circuit is a therapy, is a support system that allowed time, and the therapy did not work that you were trying to achieve the treatment. So ECMO was just a support, and the patient is dying from the natural progression of the underlying disease. So that's when you stop. What are the steps to stop? You discuss with the family, and this is an ongoing discussion. You plan for family participation and memory making, give them time. Good principles of palliative care will allow you to do that. We many times have the dogs coming to the unit, our pet dogs. We have patients having pictures with the family. We wait for family to come from other places. And then we make sure that we plan from symptom management. And remember, you have to give medication ahead of time in higher doses initially, because they get diluted on the ECMO circuit, on the membrane. So when you remove ECMO, you may see the patient being very bad situation, very uncomfortable. Then we remove the ECMO with the family present or not, depends if what their preference is. We encourage them to be there if they want to be. We have removed many times patients when the parents laying down with a teenager in the bed or in the baby being held. We remove the ventilator, we manage the symptoms again and support the family throughout of this, and support the staff, because this is very critical too. And we help the family to navigate the expected steps following death. So very important to remember, this is from Dr. Kirsch, Roxanne again, no matter what happens, these parents will be this baby's parents for the rest of their lives. You validate the joy that is intrinsic to this reality while providing space for and honoring their grief. ECMO provides also the gift of time. So this gift of time helps the parents to make meaning and memories creation. You elicit the family's hopes, dreams, and values. So you understand that they are navigating a very difficult path, and you help them to bring up what their life of that child was, pictures, and you write a diary with them, and you allow them to bring their wishes. And we have the 3 Wishes project, so the families can bring what they would like to have at the bedside as the last ritual for their child. And then the parents wish to have no regrets. But for the medical team, this means neither doing too much nor doing too little. So, but we have to reassure them that the team has done everything possible to give the child a chance to do well, but it did not work. We even use this powerful machine to keep them alive and to see if the organ will recover, but it did not work. So I reassure them that everything was done. And that's the importance of having them there, seeing everything every day with you. Some essential elements is respect for the person, individual goals, values, their needs, foster comfort, so you minimize the suffering, physical, emotional, spiritual, encourage expression of connection, dying individuals and surviving families You let them express and bring their rituals to the room, and then you preserve their dignity, give them privacy, confidentiality, and all of this is done in a collaborative approach with right skilled people at the right time with very good communication. How to do it? This is some ways that you can do it without much trauma. This left side picture is you can put the cannulas together. That's the Roxanne's paper. They show that very clear, Dr. Kirsch. And then Dr. Machado from Gainesville, Florida, gave me these two pictures where we do that too. We just clamp and we don't remove the lines and let the patient be there with the family. So this is what we do, and it has to be a beautiful experience as much as it can be. This is a way that we remove sometimes life-sustaining treatment, and we have done this not on ECMO, but with patients outside the ICU, if the patients wish that way.
My boy was sick. Our community believes that it's God who gives us breath, and when it is time, God will take it away. But while they are here on earth, our children are ours to cherish. My boy was cherished. He was an average, happy boy who played with marbles because our community does. My boy was sick. Our community believes that it's God who gives us breath, and when it is time, God will take it away. But while they are here on earth, our children are ours to cherish. My boy was cherished. He was an average, happy boy who played with marbles because our community does not believe in computers and television. When he got sick, we did not realize how badly off he was. We took him to the doctor in the next town, and that began a remarkable journey for us. We learned about machines that act as our hearts, machines that can replace our kidneys, machines that give us breath.
So when we see this scene, we remember that what we do it for a reason, because we have compassion and we have the ability to say, it's okay to stop. It's ethically sound to stop. But before starting, we have to think and plan when we're going to stop, inform the family, keep them updated, have a consensus within the team, prepare the family, plan the withdrawal, and remove it when the time comes, when there's no hope, with good symptom control, and then follow up the family. And we keep a registry and we follow up our families for a year after we do withdrawal of life-sustaining treatment of any kind, including ECMO. So thank you for this opportunity, and sorry about my technical issues. This never happened to me again, doing Zoom almost every day. So I hope that this was useful to you. Thank you very much.
Thank you, Daniel. You always have these presentations that make us really think about what we are doing, and we really appreciate that you are able to share that with us. And I think for the sake of time, you're going to use, you're going to have the poll and the questions in the end, if that's okay for everybody. And okay, let's brief a little bit. It's a very touching movie because we think about what we've been doing. Okay, so boss, it's okay that we go to the next presentation and we do the poll later? You're muted.
Yes, no problem.
Okay, so we are going to do this later on the sake of the time. Okay, so I want to present Dr. Jackie Kreutzer. She is the Division Chief of Pediatric Cardiology and the co-director of the Heart Institute at Children's Hospital of Pittsburgh and professor of the Department of Pediatrics at University of Pittsburgh School of Medicine. She is an interventional cardiologist as myself, and she is an inspiration to all women in medicine. And she will talk about the whole of interventional cardiology for the ECMO patient. Thank you, Jackie.
Thank you. Thank you very much to you, Grace, Sasha, and the organizers. It's such an honor. And welcome, everybody. Good morning, good afternoon, good evening, good night, I don't know, somewhere in the world. I'll be sharing my screen. I hope that, let's see, that works. Are you seeing the screen okay? Grace, Sasha, are you seeing my screen?
Yes, just need to go to presentation mode, but we can see it.
Oh, I am in presentation mode.
So no.
Okay.
We can see PowerPoint, but for us, it's not on presentation mode.
Is it?
Now,
or still no? Is it better now? Or is it just
yes, now it's normal.
Now it's not. Okay, perfect. Okay, so I'll be covering the role of interventional cardiology for the patient in ECMO. And these are my disclosures. So I'll try to cover when we go to the cath lab, what are the common indications that have been used in the experience published, why we go to the cath lab, some of the tips on how to cath a patient on ECMO, and the outcomes, what happens to those patients that come to the cath lab, how do they do, what are the complications that we see, and then touch on left atrial decompression and some of the outcomes from that as well. So when we go to the cath lab, we obviously have a lot of questions, and often we have some hypotheses of what happened, but that should not distract us because we often find things that are not exactly what we were anticipating. But it's very critical you talk to the surgical team, to talk to the ICU, you understand and you look at the underlying anatomy and the history really well to try to make a hypothesis on why the patient went on ECMO, what are the problems that you're expecting to find, so you look for them. If you don't look, you don't find. And then obviously the next step would be fixing things. So this is kind of our plumbing job in the cath lab, is try to figure out what we can do, not only to make the ECMO circuit function better, but then to solve the problem that may have placed the patient on ECMO, led to the patient going on ECMO. So the diagnostic evaluation is critical, the anatomic evaluation, the adequacy of the surgical repair in all the postoperative patients, and sometimes hemodynamic evaluation may be of value depending on the condition. And then obviously the interventional role, and particularly left heart decompression and other catheter interventions that we do. And sometimes ECMO can also be used as rescue for a planned catheter intervention in a hemodynamically compromised or labile patient. So if we look at, I'll use some published experiences to illustrate the different concepts that I want to share with you. So in one of the earliest studies that I'll share with you from Boston, there were 60 catheterizations in 54 ECMO patients. And the most common reason for going to the cath lab was to assess the adequacy of a surgical repair. So patients that had either could not come off pump or had arrested after cardiac surgery in the cardiac ICU. Left heart decompression was primarily the reason in 12 of those patients. And then myocarditis or cardiomyopathy assessment, mostly for biopsies and coronary assessment in patients with dysfunction. And then non-postoperative hemodynamic assessment. So outside of the perioperative period, a patient that decompensates goes on ECMO and you try to figure out what's the reason for the decompensation. Planned catheter-based interventions in 6, arrhythmia ablations for unstable intractable arrhythmias for RF ablation. So those were 3 patients. And a large percentage of these patients ended up having interventions during the cath lab or after, including surgical intervention. So it's very common that findings in the cath lab lead to an intervention that can have an effect in coming off ECMO. In the Pittsburgh experience, in 2015, we published that, and there were 40 ECMO caths in 36 patients. And again, also most commonly for postoperative assessment, planned catheter interventions, or in a non-postoperative patient are pretty similar, and then cardiomyopathy assessment. So what do we do? How do we assess? First, if there is cyanosis, if the reason why the patient could not come off pump was for cyanosis, obviously we will be focusing on causes that obstruct pulmonary blood flow, whether it's a clot in the pulmonary arteries, in a kink anastomotic, either surgical or PA plastic or pulmonary artery stenosis in particular. Pulmonary venous obstruction, we were looking for that. Left atrial hypertension, reasons why the blood flow that would not want to go into the lungs, or severe pulmonary hypertension as well. And surgical anastomotic problems, especially we look for those. This is obviously a typical example after a BT shunt with a significant obstruction in the distal part of the shunt. That obviously this is something that can be treated in the cath lab or otherwise alternatively for a shunt redo. If you have an unexplained ventricular dysfunction, the focus then goes into coronary abnormalities and selected coronary angiography, aortic root in the smaller kids, or mechanical problems that may lead to that dysfunction. And that may be ventricular outflow tract obstruction, a significant arch obstruction, residual volume load lesions, so such as significant residual septal defects or a significant collateral burden that may cause a volume load to that systemic ventricle. And of course, myocarditis and cardiomyopathy. This is an example of a finding that was surprising in a patient that had hypoplastic left heart syndrome post-Fontan with aortic atresia, who had developed a clot in a native aorta. And that clot was a little mobile, but you could see completely occluding the origin of the left coronary artery. So these findings you can see in these patients, and treating that may or not lead to survival. Angiograms depends on the site. You will likely have to clamp the ECMO circuit for a few seconds if you actually want to see anything when you're injecting in the aorta. And hemodynamic data, it's obviously questionable in a patient who is fully on full ECMO flows. However, you may be in a condition that you can lower the flows and assess hemodynamics that has maybe possible in patients that are not necessarily completely dependent or when you're trying to come off. And sometimes there are findings that are significant. So let's say you have a patient who's on full ECMO flows and you measure pulmonary artery pressure and they have severe pulmonary hypertension. I mean, that by itself is very, very important as a finding in itself. So hemodynamic data can be of value in addition to sometimes helping you figure out whether or not you can decompress you need to decompress the left side. what are the outcomes? What are the complications? What happens? In that original Boston experience, there were 2 of 60 of these catheterizations that were myocardial perforations in biopsies in patients who were fully heparinized. And overall, the outcomes, success to decannulation was 72%, survival to close to 50% survival to discharge, and longer-term survival 43%. These numbers have improved over time in some of the more recent publications that I'll share with you. And the conclusion of this original paper was that cardiac catheterization can be performed safely and that enables the diagnosis of residual lesions and facilitates important therapeutic interventions that may influence outcomes. In our Pittsburgh experience, the cannulation was 86% and survival to discharge was 72%. And now when I try to update it for this presentation, we've had 136 Ecmo caths in 110 patients, and pretty much the same survival to discharge, 71% in this population, in our population in Pittsburgh. The intermediate survival was just a little lower in the follow-up. And then it's interesting that patients who underwent catheter intervention typically had a higher survival, although because the numbers were small, this was not statistically significant. If we, over 50% of our patients, you found something in the cath lab that was unexpected, that really impacted what next steps you took in care. Some of the problems were stenotic unifocalizations, pulmonary arteries or vessels such as the superior vena cava, a restricted PDA after a hybrid procedure, significant large QPQS, advanced coronary transplant coronary disease. We had a patient with very unusual diffuse coronary disease who developed something called Cooney syndrome after just a simple septal repair in the OR. And then this thrombus about the aortic valve. So these are some of the findings which had not necessarily been expected in these patients. And here you can see an example of a completely occluded left pulmonary artery after a VT shunt and a surgical PA-plasty with ductal tissue into the LPA that had ended up forming a clot. After angiojet and then stent implantation, you can see recanalization. So in the cath lab, we can clearly treat a lot of these problems. Now in the area of PDA stenting, sometimes things can also go wrong, and we may find ourselves having to go back to the cath lab and treat an area of obstruction. And you can, we have adopted this technique for all the work that we're doing from the neck or the axillary artery that was published by Chris Petit and the CCRC group of flipping the baby, and Brian Goldstein brought that to Pittsburgh when he joined us in December. And you can flip the baby in the cath lab. It helps the operator significantly. It's a lot easier, but you flip the images because otherwise seeing the cath upside down would be really difficult. But it works very well, and I had to use that with a patient on Ecmo recently, and I was very pleased. So just a few tricks. The other, if you have an Ecmo and an open chest in an early post-op, you have to always think of the potential of using hybrid access to deliver a stent, for instance, and you can have the chance of delivering a stent that would be bigger than what you would develop percutaneously if you're limited by the size of the femoral vein. So that's another option, and you can see here how we can deliver a stent directly with access through the MPA as a hybrid procedure with help from the surgeon. We didn't really have any, you can see in the experience, most centers are now becoming very comfortable in transporting patients on Ecmo to the cath lab without complications. I mean, it's a big endeavor, but there's a really good way of doing this. And most of the complications that we had relate vascular, you can see, and this is very common in patients that have very low output syndrome for periods of time. And then you access and you occlude the femoral artery with a catheter, and you may end up seeing with signs of leg ischemia. If you look at our survival, we have a very aggressive transplant program. So a third of our patients ended up transplanted, only one directly from Ecmo, and most of them either transplanted after having decannulated or from VAD. So bridge to VAD and then transplant. Looking a little bit at other centers' experiences, in the Toronto group from 49 caths in 47 patients, the median duration between Ecmo cannulation and cath was 1 day, and the decannulation was 70% survival. Similar to has been mentioned, about one in 2 patients. And they noticed that those patients who received cath within 48 hours after ECMO had less respiratory complications and better survival at 30 days after ECMO initiation than those who underwent later cath. So, and this is depicted in this graph. You can see that the survivor for early catheterization is a lot better, significantly better than if you delay catheterization more than 48 hours. The Atlanta experience in 64 patients and 70 catheter procedures with significant number of congenital heart disease patients, 18% of them were cardiomyopathies. All of these had atrial septoplasty and a low complication rate for catheterization. They had a much better survival for the cardiomyopathy group of the patients that had come to the cath lab, especially for left atrial decompression. But then for the congenital group, catheter intervention patients did a lot better than those that did not, or those that had went back to the OR. So that's a slightly different experience, again, showing how catheter intervention can have a benefit effect, in this case, in survival. In the New York experience, they did not find survival associated to duration of ECMO cannulation and emergency septostomy. And you see that some of the studies did not. In the Seattle experience of 82 caths, 74 patients, undergoing cath or surgical intervention in 73% of the patients, one serious adverse event, which was a pulmonary artery rupture, we can see that this early catheterization was associated with a shorter ECMO duration. So again, we see that cath early, go to a cath lab early. Survival to hospital discharge was also higher in this group who had early cardiac catheterization. So very few studies have shown the survival benefit, but some indeed have. And in multivariate models, there was a significant reduction in hours of ECMO duration in those patients that had early cardiac catheterization. If you look at the survival literature, I made this graph looking at some of the papers on cath on ECMO, and survival, it's ranges pretty much with about 50 to 70% depending on the series. Going into left atrial decompression. Obviously, when you see an X-ray like that, there's no question. You should go and decompress. Now, that is still very controversial. Of course, if you have pulmonary edema, if you see a severely dilated left ventricle with decreased function, now with increased afterload from the ECMO circuit, no ejection, echo with dilated LA, left to right bowing at the atrial septum, there's no question that in those patients, we would proceed with left atrial decompression. We typically use transcatheter decompression in our center. We don't necessarily do elective decompression in all patients. Now that's still something that needs to be discussed and is controversial, and it would be great if we knew the answer to that. If it's difficult to tell whether to decompress or not, again, use hemodynamic data, measure the wedge pressure, see what it is, and then if it's elevated, you can go ahead and decompress. If you have a higher right atrial pressure and the left atrial pressure is not particularly elevated, you may decide that you need to decompress run higher ECMO flows and decompress the heart further. How do we do it? If you have a PFO, Rashkin septostomy can be performed, or especially if the patient is young, the septum tends to be thinner and easier to tear. Most of the times what we do is transseptal fracture and static balloon angioplasty with high pressure balloons. If you have a thicker septum, you can also use a cutting balloon and then a high pressure balloon. And with that, almost never we have to put a stent. Some centers though put a fair amount of stents to decompress the left atrium. Truly, whatever technique works, as long as you decompress it, it's good. You can also do a RF perforation of the septum as a technique for transseptal. Blade, I have to say, I haven't used that since I was a fellow in Boston, and it's not very commonly used. But if you have experience, wonderful. I think with transseptal and static dilation is a lot safer, and that's usually the way to go. If you look at some of the experiences with transcatheter atrial decompression, the Boston group published their experience on 44, these were 44 percutaneous atrial decompression in ECMO runs out of their larger ECMO experience. And this was achieved by a combination of doing a transeptal, putting an LA vent, and then connecting it to the ECMO circuit percutaneously, actually, or static dilation or atrial septal stent. And all these were effective. in decompressing the left heart, reducing the pressure, improving their X-ray score that they utilize. And survival was not associated with one technique versus the other. If you look at the CHOP experience, they mentioned and brought up the concept that when you open these holes, be aware that you may have to close them down the road because those holes are big, and sometimes 50% of their percutaneously created defects ended up having to then come back and get closed. Obviously, and you have a survivor, so that's not such a bad thing to have to do. In the multi-center US experience that was put together with 11 centers in the US looking specifically at transcatheter atrial decompression, you can see actually complication rates very low. There are no complications in 93% of the patients. So this is a relatively safe procedure to do. Static dilation was the most common. And when you look at the median time to decompression was 6 hours, this kind of shows you the significant variability. So still a lot of controversy and variability between different centers when they go and decompress the left heart. These are all patients that had decompression. So presumably they had an indication that some centers decompress very early, some centers decompress very late. And in a multivariate analysis, adjusting for severity of illness and comorbidities, late decompression was associated with prolonged ECMO duration, longer mechanical ventilation and ICU lengths of stay, but was not associated with hospital survival and overall survival. So obviously this is retrospective, but that's a large multi-center experience as opposed to individual centers. I also wanted to briefly mention the Melbourne experience. They were looking at elective versus urgent decompression, single center, and they found that ECMO duration was associated to the timing of left heart decompression. So again, very powerful now, over and over again. If you compress the left heart early, you are likely to come off ECMO faster. And the elective decompression was not associated to length of stay, duration of mechanical ventilation, duration of oxygen therapy, ECMO survival, or survival to PICU and discharge. So in conclusion, from some of these experiences, very low risk benefit ratio. So go to the cath lab when you cannot understand why the patient is not improving and why the patient went on ECMO. Cardiac catheterization, in over 50% of the times you can find reasons, potential problems you can fix. And these interventions can be certainly life-saving. And early catheterization appears to be beneficial for decreased ECMO duration. And we don't know, may or not improve survival. Survival may be very much dependent on the underlying condition. Transcatheter left atrial decompression is effective, it's safe, and is associated with a lower duration of ECMO. But again, the survival benefit has not been demonstrated, and the timing and whether elective decompression before you have signs of pulmonary edema it would be the way to go. That's still not answered. So thank you for your attention, and I'll take any questions.
Thank you very much. I can see there was some questions already on the Q&A. Jackie, if you're able to answer them. And then in the end, for those who can stay, we are going to have our debate session. So now we are going to have our next talk. Who is going to talk to us is Shri Deshpande. He serves as a medical director of heart transplant and advanced cardiotherapies program at Children's National and in Washington, D.C. He is active in ELSO, ISHLT, and PHTS academic community, serves in various capacities of these societies. And most recently is on the writing group of HAA, Myocarditis guideline. So he's going to talk to us about myocarditis and cardiomyopathy, ECMO and VAD as a bridge to cardiac transplant or recovery. Thank you very much, dear. Please unmute your phone or your microphone.
I will.
Yes.
Thank you, Grace. Thank you, Sasha, Gail, everybody for having me here. That's a huge honor. Welcome to all that are here, my friends Raju and Mayur from my school. it's a broad topic, myocarditis and cardiomyopathy, and also extending from ECMO to VAD as a bridge. So give me a second here. No disclosures really, but because it's a vast topic, what I wanted to do today is to focus on some key themes and get into a little bit more detail, but on some specific components of these. So I did break down the talk into 3 key areas that I thought were important. One is the timing of MCS, and I'm using MCS as mechanical circulatory support to include both ECMO and VAD. Management aspects on MCS, and lastly, transition, which would include the conversion of ECMO to VAD or bridge to transplantation and or weaning recovery. But before we get there, I just wanted to briefly review this, which is myocarditis and cardiomyopathy both can have an overlapping presentation. They can present as acute, acute on chronic, or chronic heart failure. And in majority of the patients, just supportive care, inotropic support, and heart failure therapy is adequate to see them through. But what we also know is that some patients who do present with acute heart failure and hemodynamic compromise will also have progression pretty quickly to cardiogenic shock, which can be defined as hemodynamic metabolic shock. So the progression from hemodynamic to a hemodynamic metabolic shock decompensation is a quick spiral in some of these patients, especially the fulminant myocarditis patients. And so what is the job of the MCS support is to interrupt this spiral, is to quickly interrupt this spiral. But to get there, what do we define cardiogenic shock as? And adults have defined cardiogenic shock well, but unfortunately, pediatrics hasn't done a good job of defining cardiogenic shock. So when I borrow some of the concepts from adult heart failure and cardiogenic shock guidelines, it has become apparent that a cardiac index of less than 2.2, a wedge pressure of 15 or more, in the setting of hypertension and hypoperfusion would be adequate to define a cardiogenic shock in our patients also, especially when we're talking about myocarditis cardiomyopathy population. When we review this, let's talk about when a patient is in cardiogenic shock, what is the appropriate timing for MCS? And I know this question has come up a couple of times on the Q&A and chat also, as to when do we think about putting a patient on ECMO. So let's think about what happens when we are escalating support for cardiogenic shock patients and in hospital mortality. And this is adult data, just to be very clear, but thousands of patients. And this is very, very impressive. As we go from 1 inotrope to 2 to 3, the in-hospital mortality goes up to 64%. And when we are having to use more than 4 inotropes vasopressors to support a patient, and think about it, that adds up very quickly. Milrinone, dopamine, and epinephrine, that's already 3 inotropes. You add vasopressin in there, that's 4. The mortality can be as high as 90%. Thankfully, the same may or may not be true for pediatric cardiogenic shock, but the issue is that we don't have a unifying definition for it, and also the normal excuse of having tremendous heterogeneity in our population. It becomes harder to do definitions for cardiogenic shock, and therefore come up with what are our criteria going to be for putting somebody on escalation of therapy. Again, to interrupt that mortality cycle. So the outcomes are really not well documented, like I said, and thresholds vary significantly from center to center. In some centers, they will use more appropriate criteria, which is very low thresholds basically, while some centers will use ECMO only as a last resort. So there is a tremendous amount of variation. And at this point, I wanted to open up the a quick poll, see if we can get that running. I'm requesting you to answer this for patients with acute myocarditis, very specific. What is your criteria, or what do you think is appropriate criteria for escalation to ECMO?
Shri, we wait for 50% of the people and then we stop.
Okay, just let me know.
It's amazing.
I'm sorry, it's not a standard yes or no answer. So
No, it's okay.
Yeah.
It's coming. I think, yeah, we reach 50% of the people.
okay.
Yeah.
Yeah, so that's what I suspect would be the answer, which is essentially failure of all medical therapy or quote unquote last resort. And 49%, almost half of the participants think that would be an appropriate criteria. But my hope is that at the end of the next 5 minutes, I will be able to convince you otherwise. So when we look at data about survivors of cardiogenic shock or survivors of low cardiac output, patients with myocarditis cardiomyopathy included on Ecmo. And this includes the entire ELSO registry data, as well as other experiences. And what is consistently been shown that survivors pre-Ecmo had a pH that was better than 725, had a lactate less than 9, and had an SpO2 of greater than 60%. What it means is that the survivors were earlier in the phase of the spiral down the cardiogenic shock than the non-survivors were. And this has been repeatedly shown again and again. So my approach would be to think and prepare early for supporting patients in both these categories. If a patient with myocarditis, over 6 hours period of support escalation in the setting of low cardiac output signs of low perfusion, lactic or urine output, signs of congestive injury, very important, increase in liver enzymes. Those to me are adequate to think and prepare early for escalation to MCS, because there's nothing that a medical therapy can reverse in this scenario. So that all of the medical therapies, remember, are supportive. They're not curative for myocarditis, at least early on. Similarly, for cardiomyopathy, if it's an acute or chronic heart failure, which is the most common presentation, if there's a reversible cause, such as a lung infection or something, think about that. Think about how you can cure or support that. But otherwise, a change over baseline for cardiomyopathy is an appropriate indication. So if your baseline was milrinone dependency and you're requiring more, that could be the last straw for this patient, and you need to adopt a different care pathway. So long as transplantation was discussed and or will be discussed, it is okay to escalate therapies in these patients also. As a part of the AHA guidelines, they will come out this, not a guideline, but a statement for pediatric myocarditis will come out later this year. And we'll be working on a flow chart as a part of that statement. But this is something to think about for your own institution. Come up with something, which is, for example, if you have a patient with fulminant myocarditis in cardiogenic shock, and any of the definitions that you come up with, that patient needs to be supported on Ecmo in the setting of cardiorespiratory compromise. But if you have preserved lung health, then you could consider short-term device support, such as Impella, PDMAC, Centrimac, and or Ecmo, especially for the little kids. For patients with acute or chronic failure, you probably should be thinking about durable devices straight away, not necessarily waiting for the patient to collapse on Ecmo. And then subsequent to that, you can think about for all these patients, either a weaning trial or heart transplantation. So it's important for the center to come up with what is your flow chart going to look like and what support options are you going to narrow it down to. It really is important to narrow down your support options. Are you going to use a particular device for Ecmo, a particular device for percutaneous left heart support, or a particular device for your durable support options? So it's important to have that played out first. Let's go into a couple thoughts about management on the MCS itself. And one of the things that I'm going to repeat, which two of the speakers have already alluded to, but in patients with myocarditis and cardiomyopathy, it is extremely, extremely important to perform left heart decompression early, because these are the patients that are at the highest risk for developing cardiac shunt in the cardiac patients. The other biggest cohort for us, which is the congenital heart patient, tends to have at least an atrial communication or intracardiac shunt. Patients with cardiomyopathy and myocarditis may not have adequate intracardiac shunting, and therefore do require to have early heart decompression. What we do know is that once you put a patient on ECMO, the blue PV loop is the cardiogenic shock patient. As you put them on ECMO and increase the flow, we do know that the afterload on the heart increases and the preload varies, sometimes significantly goes down. But because of the combination of these two in the setting of an acute myocardial injury, which could be myocarditis or cardiomyopathy, you will have a cardiac stent situation where your LVEDP, end-diastolic pressure, and LA pressure will go up significantly. And that will lead to pulmonary congestion, as you've seen before on ECMO, which can very rapidly progress to a whiteout X-ray. To me, having a whiteout X-ray in myocarditis is not acceptable. So what do we typically do? We would typically have an extremely low threshold for going to the cath lab and doing an atrial septostomy. Generally use a lack of pulse pressure on your arterial line, an X-ray, if not immediately post-ECMO, at 6 hours post-ECMO, repeat an X-ray and see what your lung fields look like. And then if the aortic valve is not opening and or your lung fields are whiting out, probably go to the cath lab to measure pressures, as Dr. Kreutzer said, and do a septostomy. It is really important to note that for patients who do develop a whiteout X-ray, they have a ECMO survival of 50% and a hospital discharge survival of 26% compared to the other high survival cohort who does not develop a whiteout X-ray. So this is a preventable complication of MCS in especially myocarditis cardiomyopathy patients and should be looked for early on. This is a manuscript and a review looking at the impact data. What I wanted to point out here is that when we look at left heart decompression procedures in the cath lab on ECMO patients, when the procedure was done as an emergent or salvage procedure, so left heart decompression procedure in the cath lab done as an emergent or salvage procedure, the odds ratio of early mortality is 2.7 or 2.8. So again, this is new data, this is under review, which will show that elective or early decompression of the left heart may have an advantage for survival. So again, take these patients to the cath lab or septostomy early on. For older kids now, it really is important to think about a percutaneous insertion of an Impella-like device for left heart decompression. And this concept of ECMO with Impella has gained substantial ground in the adult population and is becoming essentially a standard of care for cardiac stent. In patients greater than 30, this should be considered early. And it's really helpful for two purposes. One is to decompress the heart. And two, when you're weaning ECMO, just having Impella support ends up helping ECMO wean to just Impella and then wean the Impella off. So again, it's a good strategy to think about. Right ventricular support, if you particularly have a device in place, then a right ventricular support is really, really important to think about. As you all know, the physiology of right ventricular volume load when you put in a left VAD and an increased work demand on the RV. And this can create a situation where, in addition to the increased volume load, persistence of cardiomyopathy or insult on the RV, and additionally changes in the septal geometry once you put in an LVAD, where the septum goes bowing into the RV to bowing into the LV, can create a drop in mechanical insufficiency of the RV very quickly after an LVAD placement, especially in cardiomyopathy patients, and would lead to RV failure. RV failure is associated with poor outcomes in LVAD patients, and the risk factors for RV failure, particularly liver and renal dysfunction, have been clearly outlined. So we need to think about RV support early on in these patients, including inotropes, temporary RV support, and if those fail, then go to a durable RV support. And the last thing I wanted to talk about was transitioning. When you do have a patient on ECMO with myocarditis cardiomyopathy, when do you think about weaning trial on ECMO? Well, unlike congenital heart post-cardiotomy patients, where sometimes after an arrest or after decompensation, even 48 hours is adequate support and you can do an early weaning trial. These patients, what we have learned is that the duration of average need for a survivor on ECMO for myocarditis cardiomyopathy patients may be up to 7 days. Non-survivors who are left on ECMO longer. But what this tells me is that the median need for ECMO in these patients is really about a week of support. So really at 48 hours or 24 hours of being on ECMO, trying a wean may not be appropriate for these patients. They may require a little bit more healing time. but certainly looking at your inotrope requirement, pulse pressure, hemodynamic monitoring, and an echocardiogram while doing the ECMO wean is a reasonable thing to think about. But again, you really have to be a little bit patient with these kids and give them some time for recovery. And as it's evident, 70% of them will come off the ECMO. When you think about cardiomyopathy patients, however, that these patients, the longer they're left on ECMO, the higher likelihood of mortality. So for patients where you are thinking about cardiomyopathy, it is probably important to think about a plan for a durable conversion early on. And if there is any doubt about that, think about a biopsy at the same time. It is important because as a bridge to transplantation, it matters, and it matters a lot. If you are able to bridge a cardiomyopathy patient with VAD only, your likelihood of making it to heart transplant is 79% and a 14% VAD time mortality, so waitlist mortality. For a patient that is supported on ECMO, only 50% make it to the heart transplant and a 36% on ECMO mortality. If you convert a patient from ECMO to VAD, you only gain a little bit more, but you're never as good as VAD only support. So again, if you have a patient with acute heart failure on cardiomyopathy, the preferred mode of support is a durable VAD, not continuous flow device, but not a paracorporeal device, but a true continuous flow device in these patients. So what I have covered, hopefully, is just to give you some sense of what my take is on the timing of initiation of MCS support. Early is good. Management on MCS for ECMO, really paying attention to their LA pressures in myocarditis cardiomyopathy patient and opting for decompression. And for durable VAD patients, really paying close attention to RV support because RV failure is bad. And when thinking about transitioning or weaning for myocarditis patient, thinking about at least a week of support as a median support. But for cardiomyopathy patients, thinking about transitioning from ECMO to VAD early on is critical. So I really want to emphasize these clinical goals. The rapid identification of shock is important. We need to define it for ourselves. Importance of hemodynamic monitoring, minimizing vasopressors, so early initiation of mechanical support. And then once you are on support, thinking about weaning appropriately and or bridging to transplant early in the decision-making process. And having a shock team concept in adults is well established. We have to think about that in pediatrics. What that means is intensivists, heart failure surgeons, and heart failure transplant cardiologists coming together early on in the decision-making process. When you do that, things like this happen, wherein you can have a really good outcome for myocarditis patient. Thank you, Grace, for sharing this patient who was playing video games and extubated, doing well on fulminant myocarditis patient who's done well by history. And our little patient here at DC, who was essentially pulseless cardiomyopathy supported with ECMO for 10 days, then BiVAD for 2 weeks, and then is off all support home now. So you can have really good outcomes for these patients when you think about them well and comprehensively. That is all I had to share today. Thank you, and I'll be happy to take questions with you.
Thank you very much, Shri. It's the experience is amazing. Having myocarditis without pulse, I think, was a really successful case, and it's a big lesson for all of us. It's now time to talk about CPR, and we have one of the biggest experts, Javier Lasa, that is a cardiac critical care intensivist at Texas Children's Hospital of Houston. And at the same time, he wants to share with all of us. He's a scientist in resuscitation science, and he will broadening our understanding of resuscitation response in patients with congenital heart disease. Thank you, Javier, and sorry for the time, but it's part of the job.
Indeed, indeed. Thank you. I hope you can hear me.
Yes, very well.
Great, fantastic. Well, greetings from Houston, everyone, especially those live on YouTube. I didn't realize that we're going to be streaming live. This is just a phenomenal experience for me. I'm a new medium for information translation and transmission across the world. So good evening, good morning, good afternoon. So as the topic, as you see here on my title slide, is quite broad, I really hope that, although ambitious, we will be able to get through some of the key challenging questions facing us right now in the pediatric critical care world, in particular in the cardiac intensive care unit. From a disclosure standpoint, I am a current volunteer member with the American Heart Association's Get With the Guidelines Resuscitation Pediatric Research Task Force, which is a group that gets together to help publish important research from the in-hospital cardiac arrest registry that's been going for over 20 years now here in North America. I also am a volunteer member with the writing group with about to be published guidelines updates for pediatric advanced life support. And I'm a cardiac intensivist, which means I'm often first on the scene for a cardiac arrest. And I'm often thinking to myself, what are my options if we don't get ROSC? So this is a topic that's near and dear to my heart. It's a topic that I think is applicable. And as you'll realize, eCPR is an important indication for ECMO and is often lumped together with regards to outcomes analysis, but hopefully I can convince you that it shouldn't be. So topics for today, we're going to define eCPR quickly, talk about the importance of history and the trends, identify key knowledge gaps, but focus on one of those knowledge gaps and particularly candidacy, and then wrap up with a summary. So I think for those on the call, it's very important to understand how we define eCPR, and it sounds relatively straightforward, but as you'll see, there are some nuances that do play an important role in understanding outcomes in the literature. So eCPR is defined as the use of ECMO during active conventional cardiopulmonary resuscitation, or CPR. Indications are for refractory cardiac arrest, and the time frame is often deployed during active CPR, but as we know, there are cases of patients who've had return of spontaneous circulation, but still undergo ECMO cannulation because of concerns for persistent low cardiac output state and preventing secondary organ injury. As of right now, ELSO defines eCPR as cannulation occurring within 20 minutes of ROSC, but if it happens after 20 minutes, we get into the gray zone of, well, is this truly eCPR? And then of course, the mode is veno-arterial. It can be either central or peripheral. As we've learned from our colleagues at Sick Kids, this is a complex team choreography. And as you can see from this outline of patient's room, as well as the positions of all the individuals and technologies and equipment, it can be quite busy. And I think this is one of the most complicated things we do in the cardiac intensive care unit, the pediatric intensive care unit, sometimes in our emergency rooms. And as you'll see, out in the field for the adults. So ECLS, or ECMO's history really began in the 1960s to 1970s with the advent of portable cardiopulmonary bypass. And that's when we first started to see the use of portable ECMO for the resuscitation of adults. But it's really around the same time that Bob Bartlett, the father of ECMO, really started showing us the important role of ECMO for neonatal respiratory failure. But I found this paper from 1977, one of his seminal papers, really discussing their experience with 28 cases of adults and children at the University of Michigan that stood out to me. And in fact, one of the key comments for the abstract that said children with post-operative cardiac failure did the best. So even in the 1970s, we started to see the predominance of cardiac patients being the key recipients of this therapy. Into the 1980s, with the advent of prostaglandins, really explosion in cardiac surgery techniques and successes, we saw the use of post-cardiotomy rescue, or early eCPR. And that's right around the same time that ELSO was created. We see these two reports here, which I felt were quite important for helping us understand how important eCPR history is. And the study on the left was a single case report of the use of cardiopulmonary bypass, or extracorporeal warming, not eCPR, ECR, for a patient who was found to be submerged in very, very cold water. And after 2 hours of conventional CPR with a core temperature of 19 degrees, they placed the patient onto bypass and warmed them over 53 minutes to 37 degrees, removed them from ECMO or from bypass, and the patient walked out with intact neurologic outcomes. On the right, probably the most seminal sort of eCPR in the pediatric cardiac surgical paper published by Pedro Del Nido in 1992, which really spanned the late 80s and 90s. There was 11 patient report here. Notice the CPR duration range, anywhere from 20 to 110 minutes. And for 5 out of the 6 patients who had greater than or equal to 90 minutes of CPR, they survived. And there was a 64% survival to hospital discharge, yet neurologic outcomes were not discussed. Moving into the 90s, into the 2000s, we've seen technological advancements with program development, as we've heard from previous speakers. Again, honored to be on this panel. We've learned a lot from each other and learning that the importance of program development. We've seen that explosion, as well as the use of miniaturizing devices, better oxygenation membranes, And then, of course, we're now seeing a much broader use of eCPR and explosion in the adult population, especially with mobile or out of hospital indications for eCPR. As evidence for that, the group in France published this incredible illustrative case of eCPR performed in the Leeuwen back in 2017. This was on-site intensivist, physician, non-surgeon, percutaneous Seldinger technique eCPR cannulation happening in the field. This is phenomenal, not yet seen in the pediatric world. We're really limited to in-hospital cardiac arrest. Was still evidence of the growth of eCPR. And as we see here, eCPR has grown in terms of reported cases to ELSO. Over the last 20 years, we've seen a remarkable increase in the reports, which I would say is a proxy for actual growth of use. To parallel that, I just did a quick PubMed search looking for publications with the titles extracorporeal cardiopulmonary resuscitation, or eCPR, or E-CPR, and I filtered for children and adolescents. And as you can see here, a remarkable increase in publications on a year-to-year basis since the early 1990s all the way to the current era. I'm going to ask the group, has eCPR truly evolved? Ravi Thiagarajan, in the first publication from ELSO focusing just on eCPR, published this report from the 90s into the year 2005. You can see the use of eCPR is rising, but unfortunately survival really remains stagnant in between the 35 to 40% use. Survival. An extension of that report by Ryan Barbaro extended the ELSO database analysis from 2009 to 2015. And as you can look at the neonatal and the pediatric eCPR, and these are all comers, all different patient categories, we're really remaining stagnant right around 40 to 45% survival for eCPR cases. And again, these are patients who possibly could have otherwise died without this life-saving therapy. So in that light, this is remarkable, but how can we move the needle? Now, this is not an exhaustive attempt to document every single eCPR study, but I've tried to tabulate recent studies all the way going back to 2007 focused on eCPR, and there's a predominance of cardiac population patients in these reports. But as you can see here, we both have single center reports and multi-center collaborative and registry analyses. And you can see the spread of survival to discharge rates, but really focusing especially on the bolded studies, seeing anywhere from about 40 to 45% survival. The column on the far right was the reports, if there were any in these studies, of what was called favorable neurologic outcome. This is really the next frontier for us in the eCPR resuscitation science world, is trying to understand not only survival, but functional survival. And as you can see, there's a lot of variability in reporting, the types of measures being used, whether it be PCPC or the Vineland Adaptive Behavior Scale. And there's still a lot of work. But overall, there's about a 35 to 45% survival, similar to what Peter mentioned earlier. And favorable neurologic outcomes are reported, but quite limited, so hard to extrapolate. So what are our knowledge gaps? They're quite extensive, and I've listed them here in terms of the 5 W's and the H. So who, what, when, where, how, and why. But I think we really want to focus in this talk on patient selection. We could spend a lot of time talking about CPR cannulation choreography, where to cannulate, impact of neck versus central cannulation, how to train, what's the role of simulation, how do we activate eCPR in our institutions if the arrest occurs outside of the ICU or inside the ICU, as well as, is there a maximum duration of CPR for which we should not offer eCPR or ECMO? What's the ideal location? Should we move to the patient or bring them to the ICU for cannulation? And is pediatric advanced life support guidelines with epinephrine dosing and fixed intervals really our friend? And of course, what are we doing this for? Well, for not only survival, but for survival with intact neurologic function. So moving back to patient selection. Is it myth or is it evidence-based fact that only cardiac patients are candidates? Well, the American Heart Association's current pediatric guidelines do state that eCPR may be considered for pediatric patients with cardiac diagnoses. They say there's not enough information right now to offer eCPR for non-cardiac diagnoses, but of course, with the important disclaimer that if it's going to be offered, it should be in a location with existing ECMO protocols, expertise, and equipment. And this was extended with the first ever AHA scientific statement on CPR in infants and children with cardiac disease published by Brad Marino in 2018. It really is a compendium. I highly recommend you download it. It's quite extensive with a lot of background information and pathophysiology, understanding why patients with congenital heart disease, both single ventricle and biventricular circulations, may have an arrest and how to prevent them. But really, again, the extension that we should be considering eCPR for patients with cardiac disease, especially if there's no prompt ROSC. Now, I challenge the group. What does prompt mean? Well, we don't know. But again, we have to ensure that there's requisite resources, equipment, and infrastructure in order to offer this complex therapy. But again, why are cardiac patients singled out? Well, there's definitely evidence to support this. So I mentioned Ravi Thagarajan's paper in Circulation looking at the ELSO experience. Well, David McMullen did the exact same thing. He extended the Ecmo experience, the eCPR experience, from ELSO to patients with non-cardiac disease. And there's still a clear demarcation separating cardiac from non-cardiac in terms of percentage of patients surviving the discharge, with 38 to 42% in these ELSO registry analyses for cardiac patients versus 27 to 36 for non-cardiac patients. Now, how about if we analyze a cardiac arrest registry dedicated just to cardiac arrest and look at the eCPR experience? Both Tia Raymond and myself looked at this analysis and really confirmed that both medical and surgical cardiac subgroups did better than patients who had non-cardiac disease, whether it be medical or surgical. 48% survival for cardiac patients versus 28% non-cardiac in the Get With the Guidelines resuscitation registry. And then more contemporarily, Jeff Alton and Marissa Brunetti analyzed the Pediatric Cardiac Critical Care Consortium's registry of North American cardiac ICUs, looking at cardiac arrest incidents as well as eCPR utilization. They found that roughly 3 to 4 cardiac arrests are occurring per 1,000 patient days in North American cardiac ICUs, and that eCPR was utilized in 27% of arrests. And of those patients, 37 to 39% survived to discharge. But now we're starting to dive into the cardiac patients, and we're starting to understand which cohort survives better and in fact, those who have had recent cardiopulmonary bypass and cardiothoracic surgery did better than those who had quote unquote medical cardiac disease. Now, is there any evidence for non-cardiac patients to receive eCPR? Well, looking at term and premature neonates, David McMullen did look at this population in 2014 using the ELSO database and found that there was a 36% survival to discharge for patients who had non-cardiac disease in the neonatal intensive care unit environment. Sepsis patients performed horribly, but those with respiratory disease that were not related to congenital diaphragmatic hernia did better than expected. And extending the question of eCPR for patients who have septic shock, and in particular those with severe septic shock, a large group comprised of tertiary PICUs in Australia, New Zealand, UK, Netherlands, United States looked at severe septic shock patients who had experienced cardiac arrest or not in the setting of septic shock and who had needed ECMO or VA ECMO. So those patients who had had conventional therapy, in other words, no ECMO to manage their severe septic shock, had a survival of 40%. While interestingly, those who had required ECMO and had gone on to VA ECMO had a 50% survival. Yet those who had experienced cardiac arrest, if they did not go on to ECMO at any point in time after their arrest, either during or immediately after, there was a dismal 18% survival. While those who had experienced a cardiac arrest and had required ECMO had a 42% survival. Now, again, here we are trying to understand the data, and what we're realizing is that 69% of all those patients who had had an arrest and had ECMO were actually eCPR patients, so the vast majority. So maybe eCPR should be offered for sepsis. I think the jury is still out, and we definitely need a lot more evidence, but maybe it is myth that only cardiac patients should require eCPR. Now, back to our knowledge gaps in the patient selection. As the cardiac intensivist at the bedside, I really struggle with looking at the evidence that tells me what risk factors patients may have for mortality that occurred after ECMO cannulation. So again, looking at the timeline for patients who've had a cardiac arrest, we're really focused on a lot of analyses in terms of what are those factors associated with mortality. Well, a lot of what we're looking at is telling us what happens after they're already cannulated. But as an intensivist, I need to know whether or not this patient's a candidate before they arrest or actually while they're arresting. And so knowing that these complications are important, is valuable for us in terms of prognostication while on ECMO, conversations about futility of care. What we know from the literature is that persistent acidosis, lactate production after ECMO cannulation is a harbinger of badness. We know that if renal injury is persistent after being on ECMO for eCPR, that is also associated with mortality. Similarly, hemorrhages from the GI tract, as seen from the THAPCA subset by Kathleen Meir, as well as pulmonary hemorrhage, stroke, seizures, as well as prolonged ECMO duration are all associated with mortality. But that doesn't help me decide whether or not a patient should be an eCPR candidate. So again, what we're trying to do here is we're trying to avoid tough decisions in a bridge to nowhere. And so maybe what we should be focusing on is those factors associated with increased mortality that we can determine from before or during the arrest. We do know from the current literature that non-cardiac patients are less likely to survive, although it may not be uniform. We also know that the last pH and significant acidosis, either during CPR or immediately before ECMO cannulation, is associated with increased mortality. We know that pre-existing renal injury, as basically a marker of end organ injury going into an arrest, is also associated with increased mortality. What we don't know, and what we don't have enough evidence for, but I think there may be some conversations that should have, are patients who may have residual lesions. We know that patients with severe aortic insufficiency are not ideal ECMO candidates and are less likely to survive if placed onto ECMO during cardiac arrest. How about arrest location? Out of hospital cardiac arrest, as of right now, is really minimal indication for eCPR. I really have a hard time finding reports of this in the pediatric population. We know that eCPR that occurs in nights and weekends may be associated with longer CPR durations, although there's conflicting data in the literature with regards to survival benefits and or impacts on mortality if you do have an arrest at night or on a weekend. The first documented rhythm of bradycardia with pulse and or shockable rhythm has been shown to be associated with improved survival for eCPR patients, but we need more studies. And of course, CPR duration. While more and more evidence is telling us that the longer the duration of conventional CPR before you cannulate is associated with mortality, we have an abundance of single center reports demonstrating survivors, even with intact neurologic function, who've had 60 to 70, even 80 or 90 minutes of CPR going on to ECMO. And then really the future that's most exciting for me is really what's the impact of CPR quality on candidacy for ECMO cannulation during active CPR. If we can quantify the quality of CPR in terms of good depth and rate and diastolic blood pressures in certain goal zones and end-tidal CO2, then maybe that might be more confidence to go ahead and place the patient on ECMO. Then of course, our understanding of the use of vasoactives during CPR before cannulation on ECMO is still unknown. And so how can I get the evidence to help us answer those pre-cannulation decision questions? Well, I was very excited to see Aurelia's and Oliver's paper published this past year, looking at their experience in Switzerland, looking at eCPR over the course of around 11 years. There were 55 patients included, a little older than prior eCPR reports from other institutions and other registries at 13.5 months, but the majority had cardiac disease. CPR duration was quite long, at a median of 60 minutes, and 25% survived to hospital discharge. But what was remarkable was that they found statistically significant the length of CPR, the pre-ECMO lactate and pH, and so therefore created a scoring system to predict mortality after eCPR in the pediatric population. Surprisingly, they had an area under the receiver operating curve of around 0.74. And if you had a score greater than or equal to 9, you had a 94% positive predictive value of mortality. So I think we're starting to get somewhere with regards to how to implement potentially decision-making tools for the average intensivist at the bedside trying to decide whether or not we should activate eCPR. Similarly, Stephanie Conrad and her co-authors analyzed the extracorporeal life support organization for eCPR in patients who had normal hearts. And this was published in 2017. They did batch together adults and children for the majority of the analysis, but some of their subgroup analyses here found that pre-eCPR predictors of mortality included lower weight. And again, this was not adjusted for age, their last pH, and patients with sepsis. These were all significantly associated with mortality, yet patients with myocarditis as a diagnosis was a protective factor. So how do we translate this to the bedside? Well, I think it's really exciting to see some of the work being done in adults as well as pediatrics. Here at Texas Children's Hospital, this is our eCPR activation system. This has taken a lot of work and a lot of trials of simulations and working with a truly multidisciplinary group to try and fine tune how we get the resources to the bedside once the CICU attending decides the patient is an eCPR candidate and activates Ecmo. This may be helpful for some folks who are trying to build their own activation system. We do utilize a centralized call operating system, and that's where that star 9999 is utilized. Our charge nurse will call that to go ahead and trigger the cascade of phone calls and pages to our surgeons, to our anesthesiologists, and to our Ecmo primers. But this really still doesn't help us in terms of understanding who is the right patient. And so for that, I've here taken a couple of screenshots of really what I think may be some potentially useful algorithms. This is the adult eCPR approach from the Montreal Heart Institute, published in 2017. In the adult population, they're looking at certain contraindications like asystole, bad end titles less than 13, persistent lactates greater than 13, as well as outside business hours as contraindications for whether or not patients should be cannulated onto Ecmo during active CPR. And just published a week and a half ago by the group in Children's Hospital Philadelphia, this is their approach to the non-intensive care unit cardiac arrest. Things they're looking for in terms of patients having an arrest on the ward, acute care floor, even in the emergency department, or whether it was witnessed, if the CPR duration was less than an hour, if there was any evidence of high quality CPR with end tidal CO2 greater than 10, pH greater than 7, and all those reasons, in addition to patients with known or suspected congenital heart disease and even patients with pulmonary embolism, are eCPR candidates. So what we've learned from these groups is that we still have a lot to learn in terms of who are the right candidates. And of course, the analyses that have to occur look at the events leading up to the arrest and even during the arrest. And so in summary, eCPR utilization continues to grow, yet without strong evidence we're choosing the right patients yet. And I think we need to better define the cardiac patient population. Contraindications appear to be evolving. What is absolute right now may not be in the future, such as non-cardiac patients, as well as out-of-hospital cardiac arrest. And so what's the next step? I think we need to design eCPR decision support tools that are based in evidence and supported by all team members, because again, this is a team sport. And I'm going to go back to Dr. Bartlett's 1977 manuscript. He had a paragraph on patient selection back then. And to me, it's just striking to read this, even now in the year 2020. Ecmo support should be used for acute reversible cardiac or pulmonary failure when the risk of dying from the disease is greater than the potential risks of the procedure. Yet Ecmo is contraindicated when the prolongation of life would not add to the quality of life. And it is agonizing, insensitive, wasted effort if the acute organ failure is not reversible. Profound. I want to thank everyone again for the opportunity. Sasha, Grace, Gil, it's been phenomenal. Take care, everyone.
Thank you very much. Very, very nice talk. While I introduce our next and last speaker, thank you everybody that has already still are here. I just want to show you these two kids here. They are not my kids. I have only one boy. His name is Felipe, and these are my two eCPR patients. So one 24 minutes of cardiac arrest, septic shock, and the other one 70 minutes of cardiac arrest, first day post-op ROS procedure. So I love them. Okay, so our next speaker is Guillermo Moreno. He's the chief of pediatric CICU at Garros, a children's hospital in Buenos Aires, Argentina. And he's my colleague on the Latin America ELSO steering committee. And he's going to talk about special considerations in neonatal and infants with a functionally univentricular heart. Welcome, Guillermo. Gracias. You are muted. And we can see your screen and you're muted.
That's fine.
Oh, very good.
Okay.
Thank
Good
you.
morning. Thanks, Sasha. Thanks, Sasha. Thanks, Grace. And it's an honor for me to be part of Congenital Heart Academy. So, wow. Yes. Let me. Okay. Pediatric cardiac ECMO has been increased in the volume of cases, and single ventricle physiology has increased together. So 65% of neonatal cardiac ECMO are single ventricle. That's that show in ELSO registry in 2014, 2018. So almost 20% of neonates with congenital hypoplastic left heart syndrome will require ECMO support following Neuroprotection procedure. The risk factors for another procedure, for ECMO in other procedure, are similar to other post-cardiotomy patients, like low birth weight and longer cardiopulmonary bypass time. So, but Norwood patients have more specific risk factors, which include small ascending aorta, less than 2 millimeters, mitral stenosis and aortic atresia, intraoperative shunt revision, and RVPA versus modified VT shunts procedure. The indications for initiation ECMO also significant impact on survival. In a single standard in Boston many years ago with 44 neonates, patients cannulating for hypoxemia and particularly for shunt thrombosis had markedly improved in survival than the others who were cannulated for cardiac failure like myocardial failure or tamponade. Thinking Norwood procedures, we know the difference between Norwood with VT shunt versus Norwood with SANO or RVPA conduit. In Norwood with VT shunts, the pulmonary blood flow is in systole and diastole, so that cause, depending the shunt size, low diastolic pressure, coronary steal, and cardiac arrest. In Norwood with SANO, with ventriculotomy, the problems are of heart failure are later in the few years. What is the purpose of Norwood of ECMO in Norwood operation? Gain time for myocardial recovery. Myocardial rest, the descompressed ventricle that we saw in the previous presentation, lordosis and inotropes. That's allowed to stabilization for rule out residual defects like aortic obstruction or shunt occluded or restrictive ASD. The cannulation must be elective after conventional treatment optimized and anticipating cardiac arrest. Well, we see this compression, the ventricle before in the previous presentations. The high flow of in the arterial cannula provokes increase in afterload. That provokes failure of the aortic valve opening. The aortic valve remains closed and LV or RV delays because the blood to return to the left atrium. Impaired ventricular unloading can cause ventricular distension and may also lead increase on end diastolic pressure, increased myocardial palpitation, ischemia, and decreased coronary perfusion. How can we manage this? Well, using an arterial cannula, patient foramen oval, that in case of Norwood operation, we need to have an adequate septectomy, decreasing the ECMO pump plug that decrease the resistance or the ventricle, maintain low doses of inotropes to allow opening of the aortic valve, vasodilatation. And the echocardiography is essential to evaluate the ventricular distension. We see before in the evaluation of residual lesion. Almost 20 to 80% of the cardiac patients have residual lesions. All post-operative cardiac patients who cannot wean of the Ecmo successfully should be evaluated for the lesions. By echocardiography, we can only detect 20%, so we need to make a catheterization for the remaining 80%. Early detection of residual lesion is associated with improved and clinical outcomes. This is an excellent picture. It's published by Pittsburgh last year, and here we can see the cannulations in patients with Norwood with VT shunt and Norwood with Sano conduits. The position of the arterial cannula related to the VT shunt and the lower resistance of the pulmonary circulation related to systemic circulation make that the fluid in a great proportion is go direct to the pulmonary circulation, leading with low perfusion of the systemic circulation. Chest cannulation with open thorax is better for an emergency because the rapid access. We can use larger cannulas, better venous drainage, and we can cannulate directly aorta and right atrium. Maybe we are far in the post-operative, we can use right common carotid cannulation through the neck and right jugular vein. Well, how do we manage to prevent pulmonary overcirculation? Many years ago, there's a group who attempts to completely close the VT shunt using a clamp to prevent the overcirculation and ensure the systemic perfusion. In this case control study, 9 patients with VT shunts. In 4 patients was occluded, and 4 patients dead. In the necropsy of 2 of these patients, they found pulmonary infarct. So in the others, they could discharge home. So it's not deserved, it's not accepted anymore to occlude or to clip the shunt for optimized pulmonary circulation. The suggestion is open the shunt, trying to balance the QPQEs, optimizing blood flow with milrinone or nitroprusside for vasodilatation, increase flow to 150, 200 milliliters per kilo per minute to trying to compensate both the systemic and the pulmonary circulation, manage the mechanical ventilation as standard another procedure with low FiO2. If it's not possible, maybe restrict the shunt side with clips, but not totally clamp the shunt. Other proposed many years ago was the routine or prophylaxis with Ecmo after another procedure. In this paper, they show that they had excellent neurological outcome. They have very good numbers until the cannulation, decrease in lactic acid, in length of stays, but they have some complications like mediastinal infections, 2 patients with bleeding, 2 patients died after WIM because sepsis and inadequate oxygenating support. Maybe this is an idea in teams who are recent starting the Norwood program, but I think it's not a real recommendation to this moment. Thinking about the days, the survivors or not survivors of during the Ecmo RAM, we can see that after 9 days, there is less probability of survival of many patients. So I think in this group of patients, no more than 9 days is desirable for support. So now in the second stage, in the bidirectional glade, in an analysis using 12 years of Ecmo data in between 1999 and 2012, described 103 cases of Ecmo following a GLEM in a small infant between 3 and 12 months. They found 66 survival following cannulation and 41 survival at hospital discharge. The risk factor for mortality were requirement of inotropic support pre-Ecmo, failure combined cardiopulmonary as indication for Ecmo. In this report, the survival was better than the another report of Glenn procedure, and similar survival among eCPR versus cardiopulmonary failure. We can see here that analyzing year by year, the hospital discharge is almost 41%, and is the same during each year. About the cannulation, the optimal Ecmo configuration to support in infant with bidirectional gland is unknown at this moment. Different configuration depending on the anatomical or physiological consideration of each patient should be there. In general, 2 venous range cannulas by femoral or right atrium and another cannula in the right superior cava may be required to establish an optimum flow between 130 and 150% milliliters per minute. Finally, Ecmo in the Fontan-Kreutzer procedures, the indications of low cardiac output refractory to conventional treatment, in Fontan failure, in arrhythmia, after cardiac arrest, in respiratory failure, support for catheterization, and bridge for transplantation. In this picture, with the Fontan-Kreutzer cannulation, is really a challenge because trying to obtain an adequate venous region is important for end organ perfusion and recovery. Maybe they can achieve using 2 venous cannulas, one in the gland circulation in superior vena cava, and 1 cannula in the inferior vena cava, and a cannula in aorta. It's difficult to set this because the inadequate decompressions of the venous system. It's necessary multivenous cannula. It's very frequent. We see vessels occlusions, and the bleeding is another complication you can see very frequently. In this paper by Boston group, with 20 patients with univentricular physiology, 6 bidirectional gland, could be 2 of them could be weaned, and only 1 was discharged home, and 14 Fontan-Kreutzer procedures, only 8 could be weaned, and then only 4 could be discharged home. 50% of these patients could be successfully decannulated. Here we can see these pictures of by using the ELSO Ecmo registry data, 230 patients with 33% of them were discharged home survival, and we can see the number of the patients increased by period of years, but the survival is similar in every period at no more than 33%. Finally, factors associated with mortality in patients supported with ECMO after Kreutzer, we can see that surgical bleeding with odds ratio 2.3, the neurological complication at very high, 5.5, and renal failure is 2.52. Another important here is the duration of the ECMO. If the duration of the ECMO was less than, they found was less than 65 hours, there is an odds ratio for high mortality. That show us they were maybe bad candidates. When the duration of the ECMO was between 65 and 119 hours, these patients were successful to win. So maybe they are the good candidates. But after 119 hours, these patients were unlikely to win. So the recommendation is if no more than 119 hours is probably to win or to have a successful decannulation of this patient. Well, finally, as a conclusion, in Kreutzer operation, myocardial recovery is usually poor. Survival at hospital discharge is low, 35%. Complications increase mortality, and neurological injury are very high, 20%. There is a complex cannulation, requires multiple venous cannula, and the suggestion is begin the ECMO support before end organ failure. Thank you very much.
Thank you very much, Guillermo. Thank you very much. It was a very nice talk. I think I'm just going to tell you some things that we are going to do on Congenital Heart Academy. So what we have, let's see, okay, good. So for the next meetings, our next one on next Thursday is going to be about interventional cardiology. Dr. Ivan Zan is organizing that with us, and we are very happy to welcome all of you on that. On next Friday, on the 26th, Dr. Anderson is going to restart his sessions. So this first one of this session is going to be about ASD. It's a very nice morphological session. He goes deep on every defect. And the TGA first meeting was amazing. More than 2,000 people attended. And now we have TGA part 2. It's going to be on the 2nd of July. We welcome all of you on that. And then I hope you have liked this session. We are going to have the second part of the ECMO webinar. It's going to be on a Thursday as well, July the 9th. So we hope all of you can attend. We are preparing something very nice to all of you. We want to thank all of your delegates that is growing and growing. We are covering more areas of the world. If your country is not in red, please send us an email if you want to collaborate with Congenital Heart Academy. We are going to appreciate a lot your help. And follow us on social media. And please, we are going to send you by email, but please, if you can fill the survey, feedback survey, we want to know how we can improve. And this talk and the other talks are going to be available on Congenital Heart Academy YouTube channel, so you can take a look and send to your colleagues that you think would benefit of listen to this meeting. So I'm going to say the words to Sasha and to our one of our speakers want to say something else, we are really, really late and we are sorry for that. Thank you everybody who's stayed until now. And I don't know if our speakers want to say something before we close. Unfortunately, we won't have time for questions, but Q&A was amazing. If you didn't have the time to take a look, we are going to leave it open for more 10, 20 minutes so you can read the Q&A. It was very nice. So Jackie, Peter, if you want to say something, Guillermo.
Yeah, I just want to say thank you, Grace, and the organizers. This was amazing, such a great opportunity. I'm very grateful to have been able to participate. I really love the presentations. I got disconnected. We had like a whole shutdown of our network just after my talk finished. And I had to move to another part of the hospital. Very strange. Anyway, and it's very good to see a map with red that doesn't mean COVID cases.
Yes, this is very good. Yeah.
It's a good red. Which, anyway, I wish all the best to everyone. It was a great pleasure.
Thanks. We bring the regards from Gil that is on one ECMO patient, he told us. So it was the right meeting. And it's again, every time we finish a meeting, we say we can do better. I don't believe that we can do better than we did with all of you. It's our pleasure. Please be in contact with us. We are not an association. We are only want to be close in this moment, and we are working on this. Thank you.
Danny, do you want to say something? Shri, people who are around, Guido, Javier?
I was just going to say thank you again, and I'm happy to answer questions on email. As you saw my email on my my screen there, so everybody is welcome to send any questions, any concerns, any issues that I can help with. I'll be very pleased, and it was nice to be part of this. This is a great opportunity to disseminate knowledge.
Wonderful. I agree.
Javier, you want to say something?
Thank you, Grace.
Sure.
Thank you.
Yes, any chance. Thank you guys again.
Yep. And for participants that are there, I'll just put my box for people to have it.
Thank you very much. Thanks. Bye.
Okay. Bye-bye.
Yeah.
Thank you. We are going to leave it open so you can read the Q&A if you're interested. Bye-bye, guys. Thank you. Thank you, speakers. Thank you, everybody that watched it. Thank you.